कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Namaskar. On behalf of Team Artist and Team Dipsy, we welcome you to the SIDP Congress 2021, an initiative in South Asia for diabetes in pregnancy. Before we begin the scientific congress, we will have a brief inaugural ceremony with comments from the members of the team who have brought this program to you. Dr. Sheshayya, Patron, Dr. Hema Divakar, President SIDIP, Dr. Balaji Vijayam, Scientific Director, Dr. Sunil Gupta, Program Coordinator, and Dr. Anil Kapoor, Advisor. We now have the honor and privilege of inviting Professor Sheshayya to say a few words and declare the Congress open. Professor.
Thank you very much. Dear Anil Kapoor, dear Hema Divakar, Dr. Balaji, Dr. Sunil Gupta, I am very happy to be here. I have given a very important job of honorary in the conference. It's a very rare opportunity for me and the honor given to me. And I remember just one word in the past. We started this SAIDIP conference, South Asia Initiative Diabetes Pregnancy. This was suggested in the Ooty conference 2015. I think where Anil was there and Yam also was there. And so happened we had our great friend of mine, and so he is honorary minister, Jitendra Singh, who was there to inaugurate that conference that time. And this word was coined by our great friend and helpful to a new work of us is Dr. Anil Kapoor. And Hema Divakar took seriously this conference event. And the first conference we had in Sri Lanka, second conference was in Bangalore, and again Hema organized a meeting. Third conference would have gone Nepal, but somehow it could not materialize, and Hema has taken over and organized this conference, the virtual conference from Bangalore. I am very happy with scientific program made by this group. The topics are so good, and the speakers are again very, very appropriate. And I'm sure the audience and my friends will appreciate this conference because of the information what they're going to give. I think our friends are going to manage whatever is going to happen now. Only thing is I was thinking was, many times I find good young people go on criticizing when we speak. This may not be true, this may not. So my advice to youngsters is not to criticize anybody's work. If you don't agree with them, you go back home and do the study, see what happens. That means you must develop a constructive attitude instead of making a comment or unnecessary comment. They need doubt, they can clear. But criticizing somehow I'm not very happy. I hope this age of mine has to advise everybody should take care and then do more work, publish the work. That is the only way to convince the people. And try my whole aim in my life is I believe Indian problem needs Indian solution. So we should always try to see whatever work we do, whatever publish we do, whether it is applicable for us. Can we follow this in this country? That should be our aim. That should be our aim, my aim also, and your aim also should be there. So it is my great pleasure now to inaugurate this conference with lots of happiness to be sitting over here in this conference. All of us should be happy to participate in this conference and learn more information on the subject of diabetes and pregnancy. And they compliment artists and as well as DIPSI people for joining together and organizing this conference. I wish them all the best. Thank you very much for opportunity. Thank you.
Thank you, sir. Thank you for those encouraging and very guideful towards what attitude we should take for diabetes and pregnancy. Thank you so much, sir. I now request Dr. Hema Diwakar, President SAIDIP and Vice Chair of the FIGO PNCD Committee to speak next. Dr. Hema, please.
Namaskar. With my respects to Professor Sheshaya, the father of the GDM care in the country and beyond. In fact, the whole of Asia today is following the protocols which the Indian continent has set as a role model, because what is doable, what is feasible, what is practical and pragmatic is what the guidelines speak of, and it is our earnest endeavor to translate these guidelines and recommendations into reality. For this, we needed the support of all the concerned organizations. So connect and collaborate has always been the philosophy of ARTIST, which expands as Asian Research and Training Institute for Skill Transfer. Well, today we are connecting with all our sister organizations, the DIPSI, the FOGSI, the ICOG, the SAFOG, the DIVAS, and the AICC RCOG chapter from London too. So the wholesome approach to listening to each other, understanding the context and what best can be done given the backdrop, we bring to you the SAIDIP Congress yet again for giving some insights into ground realities in the South Asian countries. The Art of Artist, as we call ART, stands for A for advocacy. And we have consistently and constantly done enough and more advocacy, inclusive of declaring the 10th of March as the National GDM Awareness Day and the Diabetes in Pregnancy Summit that we had just 2 days ago with Honorable Minister Jitendra Singh Ji. His presence, his support, and his inspiration will take us miles ahead in this humble attempt to do our best for the girls and women in this country. So A was for advocacy. R is research. As Dr. Sheshaya said, 3 musketeers, Uday Thanawala, Sujata Mishra, and myself, when we first met him, it was Uday and me who said, we don't even know what is happening in the country. So that was some baby steps in research, if you may call, to get the knowledge, attitude, practices from all the OBGYNs right across the country, some of them still doing urine test for sugar, some doing random, some fasting, some 75, some 50, some 100, etc., etc. Huge confusion in the country that we realized, and we said, Sir said she has gotten very serious about this problem. Yes, not only that, that simple research initiative led us to understand how far and how deep we need to go. Some simple steps, but they must and sure be taken for the benefit of the generation next. And the T is the training or capacity building. Yet again, we join hands with FOGSI and DIPSI to make the first ever certification course in the world to direct the target audience of OBGYNs who will be rendered more confident and more competent to manage whenever a woman lands up with hyperglycemia, either before pregnancy, during pregnancy, and beyond pregnancy. So in a nutshell, we have been at it. We have a long way to go, but I'm sure with the support of everybody, we will be able to make a difference and innovate better and better methodologies to take the best of the care for the girls and women in this part of South Asia. So we welcome all our beloved delegates and our very distinguished colleagues from all the organizations, the CEFOG speakers who have joined us this evening, the background team which has worked very, very hard to bring this together, the 4 ICOG credit points lent by the Indian College of ONG, the 2 credit hours from the Karnataka Medical Council, which speaks of the recognition of the authenticity of the deliberations in this 2-day event. So once again, placing my heartfelt thank you for all the support from every nook and corner. We move on to the next distinguished speaker who will place some of his thoughts at the opening of the session. I may request Dr. Rita to just check if Dr. Balaji, the Secretary and Scientific Program Lead, is present here. Otherwise, you may invite Dr. Sunil Gupta to speak next.
Dr. Balaji Vijayam, Scientific Director. Are you there by any chance, sir? Okay. So I now request Dr. Sunil Gupta, the Program Coordinator, to say a few words. Dr. Sunil Gupta, please.
Namaste, and I should congratulate Dr. Hema Divakar. Single-handedly, she actually have worked hard for this particular meeting. And consistently, we have attended Sri Lanka meeting, we have attended the Bangalore meeting, and this is the third digital meeting now we have. But both of these meetings were fabulous, packed with full of academic feast across, and it was appreciated across the Asia. With the blessings of Professor Sheshaya sir, who's being called as Bhishma Pitamaha of diabetes and pregnancy in this part of the world, is I feel we should be going ahead far much faster than what we are doing now, and possibly next time we will have some more meetings in other part of South Asia. That's what we are planning earlier, but because of this corona pandemic, we could not actually plan it outside. And maybe that the group of SIDIP, which includes DIPSI, artists, and many more organizations across, including maybe sometimes Foxy and all, we should be able to do something more on these lines. We have wonderfully, I feel this National GDM Day is one of the landmark for all of us, that you have a particular day dedicated. We up till now we are celebrating only World Diabetes Day on 14th of November, but now we have for our own country, it's a National GDM Awareness Day, 10th of March, and we had wonderful program. And I was talking to Dr. Sheshaya, I feel day before yesterday, and he suggested, Sunil, it should be a diabetes week that we should be celebrating and not the day. And I go one step ahead. I say, sir, it's not only diabetes day or a week. I feel 365 days we should be continuously working for awareness of pregnancy and diabetes in this part of the world. And that should be our motto, and that should be the aggression. And on these lines, Dr. Hema, Dr. Balaji, Dr. Anil Kapoor, and many more people from Foxy and DIPSI group, they are working hard for this. Dr. Rajiv Chawla, who is presently a DIPSI president, everyone is working hard to make GDM being recognized by the society. And it should not be just the medical professional. That's, I feel now this awareness day is more focused now on educators, nutritionists, and maybe social organizations, NGOs, and they are helping us out, for making this particular entity available for their understanding, and so that we can have a holistic approach to take care of the fetuses. The Dr. Sheshaya's word, that focus fetus for future, and these are his unique words which we have picked up from DIPSI and Foxy line and National GDM Day. We have focused these lines, and so every one of us now have a focus for the fetus, for the future generations. If you want to protect future generation, we have to focus fetus, and many more things we have to learn from this 2 days conference. I once again congratulate the whole team of artists, whole team of DIPSI, and thank you very much, Dr. Sheshaya, that under your blessings, we are trying to do our best for not only spreading awareness amongst medical professionals, but also paramedical staff and the society as a whole. Congratulations once again. Thank you very much for keeping me, and it's an honor to be there on this very prestigious platform of SAIDIP. Thank you very much.
Thank you, sir. Last but not the least, Chairman of the World Diabetes Foundation, Dr. Anil Kapoor, who is the mentor and advisor, will address us before we begin the scientific conference. Dr. Anil Kapoor.
Thank you very much, Rita ji, for that introduction. I am not old enough to be a mentor to anybody, but nonetheless, thank you for those nice words. The real mentor for all this is Dr. Seshaya, and with respects to him, I would like to particularly praise my younger sister, Hema ji. She is not only a wonderful person, but is somebody who's so dedicated to this cause. And in fact, Sunil was mentioning about, and Dr. Seshaya was mentioning about how we started with SAIDIP. And it was with her ability to shoulder the responsibility that we actually got it organized. And the first meeting in Colombo was majorly successful because of what Hema put her hand up to say, yes, she'll support the Sri Lankan colleagues, Dr. Chandrika, and that's why we were able to do that. And it was a fairly large and big meeting. This was then followed because Dr. Seshaya was very keen that SAIDIP should have a meeting in India. So the next time again, Hema ji put her hand up and said, I'll organize it in Bangalore. And that was again a resoundingly successful meeting with over 500 to 600 participants and a lot of international colleagues who joined that meeting. Now, why is this meeting so relevant, and why is this so important? I work for the World Diabetes Foundation, and I would say that for the World Diabetes Foundation, one of the biggest focus areas now is addressing the links between maternal health and non-communicable diseases. And I must say that in South Asia, we have had projects addressing this issue in almost all the countries of South Asia. We have had 3 or 4 major initiatives in Pakistan, about 3 or 4 major initiatives in Bangladesh, in Sri Lanka, in India, in Nepal, and in Bhutan. And one of the largest funding that is happening is in this area. And what is amazing to me is that everywhere where we have projects, not only in South Asia, but particularly in South Asia, when we start looking for gestational diabetes, the prevalence rates that we find are mind-boggling. Be it in the rural areas of Bangladesh, or be it in the urban metro cities and big cities in India or Pakistan, the rates of gestational diabetes are really mind-boggling. And the problem is that the conundrum of how to diagnose gestational diabetes still continues. Not only is that a controversy in India, it's a controversy globally. And if some of you might have seen the recent article that was published in the New England Journal of Medicine with an editorial, which is then again starting to talk about why a 2-step process needs to be done to diagnose gestational diabetes. And I think that is all retrograde. I think what we have done in India is very pragmatic. Well, it is from a national point of view, from a program point of view, there cannot be a better approach than using the 1-step non-fasting test that DIPSI is recommended. Of course, in clinics and in academic settings, people who have all the other facilities available, they can use whatever they want to. But for a large national program, there cannot be anything as simple and as easy to implement as what has been propagated by DIPSI. We have, through SAIDIP, had the opportunity of creating a lot of advocacy work. And again, I must compliment Hema for the wonderful advocate that she is. She knows the art of communication. She knows the art of reaching out to the public. She knows the art of reaching out to the policymakers, and a lot of nice work has been done. But all this would not have been possible without the strong support of the organizations that are part of this whole South Asia initiative for diabetes in pregnancy. And that is the DIPSI, that is the FOXI, the South Asia Federation of Obstetrics and Gynecology, and many other organizations. And in particular, Hema's own organization, Artists for Her, has contributed significantly in terms of contributing not only manpower or woman power, which is more relevant than manpower, but also with financial support. So thank you, Hema. And this is the best tribute that we can all pay to our mentor, Dr. Sheshaya, who has been the guiding force for us. And I must say we have come a long way in addressing these issues, but the distance that we need to travel is much, much longer. I'd like to lastly point out that by just diagnosing and treating women during pregnancy is only 1/3 of the job. Until and unless we are able to follow up the mother and the baby, we are not doing justice to the whole effort of diagnosing gestational diabetes, because prevention will not happen until and unless we are able to provide promotive healthcare and preventive healthcare for the baby and the mother following the delivery. So thank you very much. And once again, thank you, Hema, for asking me to join this inauguration session. And I wish the conference all the success. Thank you very much.
I sincerely thank all the speakers. And before we begin on to the first session of the Congress, just a reminder that participation in this Congress entitles you to 4 ICOG credit points and 2 credit hours from the Karnataka Medical Council. So on to the first session of the Congress, which is the DIPSI session, where we will focus on the current thinkings on NCDs. To chair this session are Dr. Vijay Lakshmi Sheshadri and Dr. Shanmugam. Dr. Vijay Lakshmi Sheshadri is a senior consultant OBGYN at the Sundaram Medical Foundation, Chennai. She is also the executive committee member of the TNFOG and has been recently installed as the president of the OGSSI. Dr. Shanmugam is a professor and head of Dr. Ambedkar Institute of Diabetology, Government Kilmet Medical College, Chennai, and also a consultant diabetologist at the Chendur Diabetes Specialty Center, Chennai. He has received fellowship from the American College of Endocrinology. So the first talk in this session is by Professor Sheshaya, who will be talking on the puzzles and muddles in the guidelines of diagnosing gestational diabetes mellitus. Professor Sheshaya is a distinguished professor of the Tamil Nadu MGR Medical University. He established the first department of diabetology in India at the Madras Medical College in 1978. He is the founder patron, Diabetes in Pregnancy Study Group India, DIPSI. He has also received the Dr. B.C. Roy National Award in 1988 for the development of diabetology as a specialty in the country. And he is the first Indian to receive the Lifetime Achievement Award by the International Diabetes Federation in 2017. Professor Sheshaya.
My dear chairpersons, whom I know for many years, and I'm very thankful for them to be accepted to be a chairperson here. Today morning we got a message from Dr. Shalini Singh Jaggi. She and Dr. Ajay Chawla, they have published a paper in American Association of Clinical Endocrinologists. And as usual, I was surprised, happy to see that young person like Shalini doing very good work. I think for encouragement, I told in my inauguration, today morning I had to see that paper. She has published data on this outcome of the fetus who was diagnosed by IDP criteria as well as DIPSI criteria. So she concluded DIPSI criteria is the best criteria to be. So the compliment to her. With this, I will start on this topic. And respected chairpersons, my dear friends, ladies and gentlemen, slide. Slide. As I mentioned earlier, I am going to speak on this topic, puzzle and muddle in the guidelines for diagnosed GDM. And I will have to take some few minutes in this, why I am calling that puzzle, muddle, how we are going to find out the riddle for this. So next slide I want to hear will be, friends, the SIDP diabetes mellitus has been included the classification of diabetes mellitus, yet there is no global uniformity in the guidelines to diagnose GDM. O7 first used the terminology gestational diabetes in 1961, following the term meta-gestational diabetes used by Dr. Hood in 1954. Historically, initially the diagnostic criteria were suggested by O'Sullivan and Mahon, followed by the Carpenter and Couston. The model is, you'll see here now, at present there are 11 guidelines for diagnosed GDM. And we hope that among them we thought International Association of Diabetes Mellitus Group, the IADPG guideline was expect to settle the diagnostic criteria issues. Our expectation was there, but it doesn't seem to be happening. That's why I call the model. Now, in the city of Pasadena, what happened, I'm just telling the history, what happened in USA in 2008, a consensus meeting of IADPG group was held. Most of the delegates voted for OR of 1.75 for diagnosed GDM. A few countries, including India, opted for OR 1.5 because our problem is different compared to Western world, that is 1.5. But unfortunately, as far as what may be there, IADPG followed 1.75 ratio. Now we'll see what could be the cause here. Based on the hyperglycemia and adverse pregnancy outcome study performed in Caucasian population. Please note this, Caucasian population. They never had any other population except Bangkok and Hong Kong. IADPG suggested the diagnosis of GDM can be made when any of the following plasma glucose value meets or exceeds. What is that? Fasting plasma glucose more than 92 milligrams, or 1 hour more than 180 milligrams, and 2 hours more than 153. That is the suggestion given by APO study and based on the 1.75 ratio. Now, how this has been appreciated or how they are able to introduce this, and the WHO had its own problem. I will see here what could be, what is happening here. I am telling the data now. Sachs et al. Is one of the very big man in this group, mentioned that this sentence is very important. Center to center differences occur in GDM frequency and relative diagnostic importance of fasting 1 hour and 2 hour glucose levels. This may impact strategies used for the diagnosed GDM. That means what he meant was, it depends on the centers. One center may for fasting, one person may be 1 hour. What is it? Or 2 hours value. Now I took a study of our own data on 1,146 data. We want to apply this criteria given by the IADPG and what our friend, Sachs told about that. In this, you will see here, suppose A center, suppose Delhi follows only FBG for diagnosed GDM. It will be 136 out of 1,463, 9.30%. So Samba center in Bombay follows only 1 hour post plasma glucose, 180, 65, the 4.40. And same another center follows only 2 hours for diagnosed GDM, 98.7. So you will appreciate from this slide what Sachs is feeling. The commented was it is going to be a problem because it all depends on how the country is going to follow fasting 1 hour or 2 hours. Then the next problem was IDG methodology to derive prevalence of GDM is by measuring What's the prevalence of, as per IDP? Not I just now told about the diagnosis. Here, fasting plasma glucose alone must be taken into consideration, and then adding measurement of 1 hour plasma glucose, identified additional prevalence, and finally adding the 2 hour plasma glucose measurement. So how complicated this problem of finding out the measure of the prevalence of IDP, prevalence of GDM as per IDP criteria. How many people can follow this? How many are really following? Sometimes I get the paper for reference. I ask them how you did it. Then whatever they realize that I'm not able to understand what they're telling, how they're doing it. That is because of this complicated problem here. Now, how a few investigators follow methodology to find out the prevalence. What happened here? Again, 1.75 odds ratio. 92, as I told you, 9.3%, and 1 hour 180 milligram 4.4%, and 2 hour PG 143 6.7%. Adding together it became 20.40%. But what IDP told is different. What we are doing is different. Now I'll tell you what IDPG thought was, how IDPG guidelines is here. So this method is wrong. So what is correct method IDP told, but how many people following, I have no idea at all, because this is very difficult. And then here this is what happened. You do the fasting plasma glucose 92, 136, 9.30%. Next step will be you must take 1,463 minus 136, which is already gone. Balance will be 1,327. In this 1,327, 1 hour PG more 80 milligram was 36 and 2.46%. Third step will be now, out of 1,136, you must remove this also 1,291. And then it will be again 2.46. Third step will be here, out of 1,327, 36 already removed. So 1,291 in that, 2 hour PG will be about 143 will be 42, that 2.87. The correct method is this. So that's what IDPG told. But what the previous slide I told you is different. Now, if you apply this correctly, the prevalence is only for 14.6%, not 20%. So that is a big problem. That is why I call them IDP guideline is muddle. What happened here? A reason why I'm not telling. I'm quoting here, a recent publication has stated that even at centers, the accepted IIDP recommendation, the approach varies from center to center and needs revision for standardization of the strategy for diagnosed GDM. They told by Boyd Mercer, the author of IIDP guidelines in September 2018, as recently. So this is why I call it muddle. Now we'll see what is the puzzle. The puzzle here is, you will be surprised to know that a recent study used where, not in India, in states. Recently used Carpenter and Costin criteria for diagnosing GDM, which has already become obsolete. This is a very big man, Samantha in the United States, and he is using the country which created this IDP criteria is not using, they are using old Carpenter and Costin criteria. So that is why I became puzzled why it is happening here. So now let us solve the problem. So diagnostic criteria based on the AMPO study here, this is interesting comparison. 1.75 odd ratio, fasting 92, 1 hour 180, 130, which I already dealt with. Now if they suppose IDPG in the persona, the accepted 1.5 odd ratio, the number will be 90, 160, roughly 140. What is the advantage of this 1.5 odd ratio? It's not only good for India, but also for other countries also. It's so simple here. If IDP had accepted 1.5 odd ratio, the prevalence would be same, the fasting 1 hour and 2 hour. That is, fasting 183, 12.5%, only 1 hour 160, prevalence 190, 12.9%, and 2 hour 196. That means any one value which you use, you are going to get the same number of diagnosis. That is why we thought it could have 1.5. If 1.75, this will not occur. If it accepted 1.5 R ratio, this was possible to address this could have been possible. Now, having done that, having accepted that 140 is the better value, what are the evidences? I'm coming to last leg of my talk here. And if 140 blood sugar crossing 50% beta cell function will be lost, so 140 has got justification to be diagnosed. And as this Foxy Figo told, if in the non-point state, 2-PG more 140 is considered abnormal, then why can't it be considered abnormal during pregnancy? So diagnosis of GDM with 2-PG more than 140 milligram and treatment is worthwhile. The decrease in macrosomia rate, fewer emergency sections, serious parental morbidity may also improve the woman's health-related quality of life. So having accepted that, now we'll see what is the evidence. I think as I mentioned that on 10th of March, that the greatest work was done by our colleague, Dr. Professor Jachandra Singh, the minister now. He done a wonderful study which is rare, which cannot repeat again. It took control of 140, GDM with treatment 70, and GDM not accepted 22. But somehow it happened, those Dogra girls, probably ladies didn't want any treatment, 62 was controlled. It so happened. So when followed up, we found out the stillbirth was 3, 4, and then preterm less 36, 37 was 2.8 in the controls, whereas it is with the treatment 4.2. It is enormously high level in 16.3, 4 times more than, 8 times more than control. So it shows how bad that keeping the 140 blood sugar level. Respiratory distress syndrome again 3%, macrosomia 4 kg, 1.4, 1.4, 2.8, again 9 times. So we can easily understand this. GDM not followed the 140 and above, all the products going to occur. So this study proves advantage of adhering to the DIPSI guidelines in the diagnosis of GDM and management of GDM for a significantly positive effect on pregnant outcome. So now as Anil Kapoor was telling, we are not against IDPG. The problem is how it's difficult to follow and difficult to follow. But DIPSI is very simple. And now this another study which we published here, the criteria and the prevalence of GDM. If you follow IDP 3 blood tests, fasting, as I previously told, 3 blood tests, it will be 14.6%. If DIPSI test 140 milligrams, 13.4%. Difference 1.2. That shows there is no difference if you follow the DIPSI criteria or IDP criteria, but the problem will be no expenses. Here you'll see discordant pair between the 2 criteria indicated no statistical difference and thereby implying a close agreement between these 2 diagnostic procedures. So most cost-effective diagnostic test is the less source community will be again DIPSI. DIPSI procedure requires 1 blood sample drawn and 2 hours or 70 grams. All of you know, DIPSI procedure is feasible, sustainable, cost-effective, and high impact best buy for less. So a recent publication I quoted in the just before that Sarani Jaggi and Sajesh Chawla has published the data. This is almost like us. No, so the justification, the importance of, you'll see DIPSI here, it was published in Strategies of Diagnosed Gestational Diabetes in the DRCP journal. 2-hour blood sugar was in the by WHO 2013. It's similar to IDPG. And then non-fasting 70 gram, they're comparing both IDPG and DIPSI. It is wonderfully agree here. You see this, the performance of WHO 2013 and DIPSI criteria are same in outcomes, because you'll see in this slide almost same, that red and green. So that is why we are saying DIPSI criteria is as good or as even better than for the countries in the less societies. So now I'm coming to last 2 slides. Diagnostic criteria studies used for estimating gestational diabetes, IDF study. This they have included now DIPSI criteria also 2014, and 7.8 millimole. And same thing you will see in the NICE guidelines also, it is 1.8. So we have got another evidence from other country. UK is because acceptable because it is a multi-ethnic population. It is not like other countries where only pure race are there. That is why I said NICE will take it as a guide, and DIPSI and NICE are almost same. Now, finally, friends, there are very, very rich people are there. As Anil was telling me, big centers, hospital, they can also, whatever test they want to do, let them do any test as possible. But what, as my aim was the 40 years, my whole work was for the poor people or less people who cannot get the test done. So in this population, this is done by Dr. Bhavadharani in Europe to prove that only 9 come with the fasting out of 4,000. That shows fasting don't come either. 80% of women came in the non-fasting state. So a test must be simpler and feasible in everybody, and that is what we call it. This is a simple economic test. This again, Anil Kapoor was one of the funding fellow, WDF funding was the guidelines and diagnostic criteria, just simple, feasible, and ground is important. This was published in the BMC Journal, Pregnancy and Child in 2017. So, friends, my final slide is the riddle. I said muddle, and now the riddle can be solved by following the evidence-based diagnostic criteria of DIPSI recommended by Minister of Health, Government of India, approved by World Health Organization, FIGO and IDF. My dear friends, you are listening to this, and whenever you go and talk, anywhere you can talk, but see that it's very difficult for us to, okay, IDP may be there, but very difficult for a country like us to follow. So our South Asian countries, and I think nowadays, even some Sub-Saharan countries are trying to follow DIPSI guidelines. So thank you very much for your passion, Danny. Hope we'll follow only our own guidelines. It's called Indian problem, needs Indian solution. We'll follow our own guidelines. Thank you very much.
Thank you, Professor, for that wonderful talk and bringing clarity in the confusing scenes of diagnosis for gestational diabetes. We now move on to the next speaker of the day, that is Dr. Samar Banerjee, who will be talking on biomarkers in GDM. Is there a scope for prevention? Dr. Samar Banerjee is the professor and specialist diabetes clinic in Department of Medicine, Vivekanand Institute of Medical Sciences, Kolkata. He is also the recipient of Leadership in Diabetes by the ADA in 2016, has received the Lifetime Achievement Award by DIPSI in 2016. He's also been the past president of the RSSDI, Indian Society of Hypertension and DIPSI. He's the president, Association of Clinical Diabetology, and editor-in-chief, the Journal of Clinical Diabetology. I now hand it over to the chairpersons for their comments and their questions, and Dr. Samar Banerjee will be the next speaker.
I request to allow me to share the screen. Hello?
Sir, you can share the screen, sir.
No, they are showing that you cannot share screen while the other participant is sharing. I am not allowed to share the screen. Please allow me.
Support, could you just send a request to sir for sharing the screen?
Sir, it's already allowed. You can share your screen.
Okay. Thanks to the organizer of this SIDP to give me the chance to speak on the topic on the biomarkers in GDM scope for early prevention. I know that this topic is going to be a little difficult and unassimilable, but my mentor, Professor Sese, has nicely placed how to diagnose diabetes in pregnancy with blood sugar estimation. But we all believe and accept that when we diagnose the blood sugar high in cases of pregnancy, the epigenetic changes and the metabolic changes in fetus has already started. So the problems in the fetus and the mother during the pregnancy, after the pregnancy is not totally avoidable. So if we can detect some biomarkers, which will detect that the patient will develop GDM, even when the blood sugar is not raised, it will help us a lot. I'll start my lecture by offering my pranam to Guru, Professor V. Sesaiya, who not only taught me pregnancy diabetes, but he told the whole world what is pregnancy diabetes, where is pregnancy diabetes, and how is the status of pregnancy diabetes. Norman Franklin told, no single period in human development provides a greater potential than pregnancy for long-range payoff by a relatively short-range period of enlightened metabolic manipulation. The slogan of DIPSI is F4, that is, if you can prevent focus on the fetus and you can prevent the problems in the fetus in future and also in the adult. So for properly treating pregnancy for only 9 months, you can avoid the problems related to pregnancy diabetes, both in the mother and the fetus in future. Currently, the GDM diagnosis is made during the late second trimester, possibly exposing the infant to intrauterine metabolic alteration and epigenetic programming for a significant period of time, which can predispose infants to long-term pathology. But DIPSI has advised to start minimally at the first trimester, and I practice the moment a pregnancy patient comes to us. Detection and management of GDM in pregnancy can reduce the frequency of adverse pregnancy outcome. Hence, there is need to predict and detect GDM earlier in pregnancy in order to limit the exposure to impaired glucose metabolization. Identification of early biomarkers in pregnant women who subsequently develop GDM may result in improved understanding of GDM pathogenesis. Combining biomarkers and risk factors into a predictive model may add to early prediction of GDM, evoke effective prevention strategies, ultimately reduce complications. And this is the unique picture. It may be a very complicated. What is the pathology and how to prevent the problem? The main pathology is inflammation, insulin resistance, and these are common in obesity, pregnancy, and GDM. So insulin resistance are becoming very high due to high free fatty acid, triglyceride, low vitamin D, beta cell dysfunction, growth factor remodeling, and adipokines. And also the inflammation is high. I will discuss all the markers later on. So GDM develops and beta cell dysfunction coexist and may be characterized by further abnormalities in adipokine and cytokine profiles, increased free fatty acid, triglyceride, low vitamin D, and endothelial dysfunction. And the biomarkers are based on this point. To discuss briefly, the glycemic markers as a biomarker, you know, as the fasting glucose, post-load glucose, A1C, fasting insulin, sex hormone binding globulin, C-reactive protein, TNF-alpha, leptin, adiponectin, restin, vispatin, polystatin like 3, placenta growth factor, placental exosome, and also glycosylated fibronectin, soluble protein receptor, alanine aminotransferase, and ferritin. The epigenetic footprint, metabolic alterations such as impaired glycemic control during fetal development can lead to functional and structural alteration in the fetus, resulting in predisposition for developing epigenetic changes and chronic metabolic diseases later in life. These are the changes in the biochemical structures of DNA that ultimately alters the gene expression. And what are they? DNA methylation, histone modification, and non-coding RNA process. Why we need earliest detection? Maternal insulin resistance also causes insulin resistance in the fetus, and multiple studies have linked maternal GDM with the development of obesity and type 2 in children, who are 8 times more likely to develop type 2 diabetes than non-GDM mother children. Obesity, inflammation, and GDM, what is the link? More women of childbearing age are entering pregnancy being overweight or obese. Obese have a threefold risk for GDM. Global increase in GDM largely attributed to the ongoing obesity pandemic. and it is characterized by altered production of pro-inflammatory cytokines by adipocytes, causing a state of chronic low-grade inflammation, which is a stimulator for damages in the pregnancy. It drives the expression and production of TNF-alpha, interleukin-6, anti-inflammatory cytokines, and many adipokines. The adipokines modify insulin secretion and sensitivity, appetite, energy control, and inflammation. Sound relationship persists between the obesity, chronic low-grade inflammation, and development of type 2. In normal pregnancy, there is a delicate balance between the production of pro and anti-inflammatory cytokines. Some are facilitating the patient, some are damaging the patient. Pregnancies in obese further enhance the pro-inflammatory profile, leading to an imbalance and therefore possible complications. The role of inflammation is a feature definite in GDM. The increased production of pro-inflammatory cytokine debilitates insulin signaling. A down-regulation of adiponectin and anti-inflammatory markers such as IL-4 and IL-10, and an enhanced production of pro-inflammatory cytokine IL-6 and TNF-alpha may be observed. IL-4, IL-10, and adiponectin are protective. IL-6 and TNF-alpha are damaging. Adiponectin and adipocyte-derived protein contains anti-atherogenic, anti-inflammatory, and insulin sensitizing factors. And these are inversely correlated with obesity, hypertension, dyslipidemia, and coronary disease. That means it is this protective factor are diminished in these diseases. Decreased level associated with an increased risk of type 2. Decreased adiponectin progressively during normal pregnancy, probably in response to decreased insulin sensitivity. Reduced adiponectin levels seen during mid-pregnancy in GDM relate to the onset of insulin resistance and diminished beta cell function. So detection of reduced adiponectin can predict development of GDM. Lower level of adiponectin in the first trimester of pregnancy associated with a greater risk of GDM, suggesting that a down regulation of adiponectin may be a predictor of GDM. A case control study showed that low pre-pregnancy adiponectin, this is a very interesting study, so long I discussed about the biomarkers during pregnancy. But this study showed that low pre-pregnancy adiponectin, before pregnancy, 5-fold increased risk of developing GDM. So now time has come to not only do the blood sugar in the ladies before becoming pregnant, but also measure the inflammatory marker. This remained significant after association for known risk factors of GDM. This might be relevant for clinical practice as it identifies a group of high-risk women that might otherwise not have been identified. An adiponectin therapy has been tested in animal models of obesity, and it has been shown to improve glycemia and reduce hyperinsulinemia without alteration in body weight. Till date, there is no data of adiponectin therapy in diabetes pregnancy. In summary, lower levels of adiponectin are linked to obesity, type 2, and GDM, may play a role in the pathophysiology of GDM and can be seen as a promising predictive biomarker, not done during pregnancy, but even before pregnancy. Leptin, predominantly produced by adipocyte, but also produced in ovaries and placenta, regulates energy balance through hypothalamic pathway. Increased leptin associated with weight gain, obesity, and hyperinsulinemia. Maternal leptin levels are known to increase 2 to 3-fold in pregnancy, probably from the placental secretion. Increased leptin have been reported in women with GDM. Inflammatory markers like IL-6 and TNF-alpha probably also play a role in the pathophysiology of GDM by promoting chronic low-grade inflammation while further increasing the concentration. So interleukin-6, TNF-alpha also stimulate leptin concentration and make the situation worsen. A prospective cohort study reported increased concentration of leptin before 16 weeks of gestation, independent of adiposity, which are associated with increased risk of GDM. So this is another paper which highlights that if you measure leptin and it is high within 16 weeks of becoming pregnant, you can predict GDM. Another study, leptin was increased in all women during pregnancy with the highest concentration in women GDM, obese GDM. Current evidence is limited in part due to confining effects of measures of adiposity. Leptin is likely to be involved in the pathophysiology of GDM, but appears to be a poor predictor of GDM. Vispatin, this is another adipokine mostly produced by visceral fat. In pregnancy, vispatin level progressively increase up to the second trimester, after which a decrease again with the lowest concentration observed in the third trimester. In GDM, vispatin level have thus far been inconsistent, as both decreased and increased levels have been reported. One study showed vispatin in the first trimester were better in the prediction of GDM compared with C-reactive protein, IL-6, adiponectin, and leptin. Another study in the first trimester showed that vispatin was increased in GDM group, but when added to other maternal risk factors, the GDM detection rate did not improve. Result thus suggests that vispatin is a potential biomarker in GDM, but additional studies will be required to establish the exact value and its fluctuation. Restin, another adipocyte-derived hormone which is increased in obesity. A potential link between restin, adiposity, and insulin resistance in pregnancy might exist, but to date remains inconclusive due to conflicting reports from case control studies. Other markers, they are produced by the monocytes and macrophages. They affect insulin sensitivity, secretion through impairing beta cell function during GDM. Multiple studies reported increased maternal TNF-alpha level in subjects with GDM, predominantly late pregnancy. Increased TNF-alpha in GDM versus control have been shown. Subgroup analysis revealed that these relationships remain significant when compared with BMI matched control. So this does not depend upon the BMI. The increased levels are thought to be due to increased oxidative stress and inflammation associated with impaired glucose metabolism. On small nested case control study with only 14 cases and 14 control addressing the predictive value of TNF-alpha showed no difference between women with GDM and control. But in another study, TNF-alpha were increased at 34 to 36 weeks of gestation and were inversely correlated with inverse insulin sensitivity. HSCRP or high sensitivity C-reactive protein are elevated in early trimester after adjusting for pre-pregnancy BMI, family history of diabetes, nulliparity. Women with CRP in the highest quartile who have got higher level at a 3.5-fold increased risk of GDM. Wolf and co-workers also reported that first trimester CRP level was significantly increased among women who subsequently developed GDM. And after adjusting for different parameters, C-reactive protein among the GDM women was in the highest quartile compared with the lowest and was 3.6 times higher. So low CRP in pregnancy, higher CRP have got 3.6 times the predictability of GDM. When adjusted for BMI, this association was not found anymore, however. Bergen and workers, first trimester HSCRP was predictive for third trimester impaired glucose tolerance, but again the association disappeared when adjusted for BMI. Thus, the positive association of HSCRP and GDM seems to be in part mediated by BMI. Sex hormone binding globulin has been proposed as a marker in insulin resistance. Indeed, a relationship between low levels of SHBG and T2DM has been reported. A study evaluating the serum SHBG reported that SHBG concentration was significantly lower in GDM than in normal pregnancy. Adding HSCRP increases the specificity to 75.46%. Other potential biomarkers, the adipocyte fatty acid binding protein. Two studies have reported increased concentration in gestational diabetes. Plasma insulin and adiponectin concentration when measured at 11 walks together may be predicted of impending gestational diabetes. Interleukin-6, a pro-inflammatory markers, the relationship between UL6 and insulin action appears to be regulated by adiposity. However, in a case control study, IL-6 levels have shown to be elevated when even adjusted for BMI in presence of gestational diabetes. Low level of vitamin D have been associated with obesity and type 2 in pregnancy. In the first trimester, low level were associated with the higher risk for GDM. Recent meta-analysis have supported this finding, but the included studies were not all randomized control study. So we need further more RCTs. Clinical prediction model incorporating biomarker. Clinical risk prediction model we have investigated in gestational diabetes. For example, together with the biomarker, you will have to also include ethnicity, family history of GDM, and BMI. A large prospective study, the best performing model based on these factors, showed a sensitivity, specificity, and area under curve of 73%, 81%, and 0.082 respectively for the identification of GDM cases requiring insulin therapy. So if you combine biomarkers with the clinical markers, then you become more successful. For example, tissue plasminogen activator and low HDL cholesterol were independent significant predictor of GDM. TPA in the prediction of GDM is a novel finding. Another study demonstrated that elevated plasma insulin and reduced adiponectin level in the first trimester improved GDM diagnosis. Maternal risk factor also showed a prediction rate of 61% for GDM, adding adiponectin and SIDP increased detection rate to 74%. Metabolomic, 6 metabolites, anthanolic acid, alanine, glutamate, creatinine, allantoin, and serine, were identified as having significantly different levels between the two groups in conditional logistic regression analysis and was found to be altered in presence of GDM. Endogenous galanin at the higher level of galanin observed in GDM may represent an adaptation to the rise of glucose, weight, GGT associated with GDM. So higher level of galanin may be present before GDM develops. Similarly, 1,5-anhydroglucitrol level are significantly lower in those who will develop GDM in future. Placental growth factor, a vascular endothelial growth factor like protein, if higher early pregnancy, also can predict GDM. Recently, ALT, a liver enzyme often used as a marker of hepatocellular damage, has been shown to be associated with development of first trimester GDM. One moderate size study suggested that glycosylated fibronectin also can predict future GDM with high accuracy. Watanabe measured soluble protein receptor and found relation with the GDM. Plasma glycated CD59 was found to be an accurate biomarker for the early prediction of gestational diabetes and also can predict infant malformation, neonatal hypoglycemia, or delivering an large for gestational age. A growing body of evidence supports the use of SNP, single nuclear protein, DNA methylation, and microRNAs as biomarkers for GDM. Insulin and C-peptide level is also a biomarker for GDM. Dysbiosis of gut microbiota may modulate the development of GDM and serve as a diagnostic biomarker. And the actinobacteria, proteobacteria, and firmicutes are taxonomic biomarkers of GDM. They are very much indicating if present in the gut. Healthy pregnant women have higher Rosburgia, Fusobacterium, and Hemobilus and Bifidobacterium. So if you find these in the gut, this can predict GDM. If you find these, it will predict normal pregnancy. So this is briefly the predictive and diagnostic biomarkers of the GDM. I have discussed majority of the points, which together with insulin resistance, inflammation, placenta dysregulation, and beta cell injury will lead to GDM development and associated disorder which can develop in the perinatal phase, insulin resistance, beta cell function, and then altered cardiac structure, arterial stiffness leading to coronary artery disease, hypertension, etc. in neonate, insulin resistance, macrosomia, stillbirth. For the woman, metabolic syndrome, subclinical inflammation, cardiac hypertrophy, systolic diastolic dysfunction, vasculopathy. In the children in the long run, obesity, hyperglycemia, hypertension, cardiac hypertrophy, diastolic dysfunction, vasculopathy. So what I like to highlight before you, if I just wait for the only rise of blood sugar, we are already late. We have always started working before, and this is a real preventive medicine. If we can establish, if we can summarize and come up with the real biomarkers, which will predict the development of hyperglycemia in pregnancy and halt at that stage and check at this stage, we can do a lot to prevent the spread of diabetes. A diversity of biomarkers, including glycemic, inflammatory, insulin resistance, adipocyte-derived and plasma-derived, have been examined as methods for identifying risk of GDM early in pregnancy before fetal overgrowth begins. Fetal overgrowth starts within 6 to 8 weeks. Are lacking, this could be valuable for identifying women who might benefit most from more intensive antenatal monitoring and intervention. The majority of studies reporting an association between first trimester biochemical parameters and GDM have been small in size and have utilized case control design. A few large studies of glycemic markers have suggested that fasting glucose or hemoglobin A1C may be useful for identifying women without overt pre-existing diabetes who could benefit from early GDM treatment, but this has to be shown in interventional studies. In order to translate the findings from observational studies to clinical practice, we need more trials or cost-effectiveness analysis of screening and treatment approaches based on first trimester biochemical GDM predictors. Future research should test first trimester biochemical markers. I've discussed adiponectin, TNF-alpha, which can predict even before pregnancy. In addition, strategies that utilize first trimester biomarkers and clinical risk factors to identify women who do not require additional screening should be examined for effects on both outcome and cost. So I just like to highlight, let us standardize the biomarkers, and if they come to be really helping, at present moment, TNF-alpha, insulin resistance, HSCRP and some others are very much promising. And even if we do this before pregnancy, we can thoroughly check the explore of future diabetes and also the pregnancy complication, which we mostly observe in cases of pregnancy. Usually we diagnose hyperglycemia in pregnancy when it is advanced, when the fetus is already damaged, and even the fetus is normally born. There are so many complications in the adult, in the newborn. Thank you for your patient hearing, and I just express my gratitude to you for making all these 4 books my successful. Thank you for your patient hearing. Thank you.
Thank you, sir. Dr. Samar Banerjee, thanks a lot. First, I would like to thank Dr. Hema Divakar for this opportunity. And it is really a proud moment for me to have chaired the session where both Professor Seshaya and Dr. Samar Banerjee are there. It's a real great honor for me. Thank you, Hema, for this wonderful opportunity. As Sir said, Professor Seshaya said the puzzle, the muddle, the riddle. I mean, it was really nice to see that we are going through lots of changes, but yet I feel the OB Gynec Society has still a long way to go to make it completely universal. Although I'm very proud that being in Chennai, we are completely with Professor Seshaya. And as I cross his center every day, I really do give a big pranam to that center, having done lots and lots of work. And really all of us OGians in Chennai, we are really very appreciative and we are in unison with his views. But of course, as he says, there are lots of puzzles and muddles still to be solved. And hopefully in very, very, very short time, we will be completely universalized in the screening of diabetes. And Dr. Samar sir, of course, it was a little quite complicated, as you said. And but only I was just thinking as to whether these are easily available, the biomarkers to be done. And number 2, is there a threshold value where we can say to equate with the blood sugar levels?
At present moment, you can easily do the HOMA-IR, which we determine by fasting blood sugar and serum insulin in the same sample. Fasting blood sugar in millimole multiplied by serum insulin divided by 22.5. It is more than 1.3. We accept the patient has got insulin resistance. Second point, HSCRP is mostly done in many parts of the country. And now after the COVID, we are very much conversant with the interleukin 6, TNF-alpha, etc. But I just surrender. This is in the very primitive, very infantile stage. But I am very hopeful. Again, I repeat, when we do blood sugar and detect hyperglycemia, fetus has already damaged. So we should not allow any damage in the fetus. We should try before pregnancy, even in high ESR, high C-reactive protein, very easily can be done, and HOMA-IR, and I can tell the patient that you should take care, particularly for control of obesity. And this is the ideal space when I come across with unmarried polycystic ovary. I all tell them, you reduce your body weight, you can avoid your pregnancy problem. Thank you. This is a developing subject. Hope
Yes,
it will
sir.
be stabilized.
Thank you so much, sir. That was really wonderful. As you said, we have a long way to go to accept all those and to know more about it. Thank you so much, sir. And probably once we are into the real detection of these markers, maybe the fetal origin of adult disease can come down in the future generations. Thank you so much, sir. Over to Dr. Shanmugam for his.
Yeah, thank you, madam. Thank you. I have to thank my my mentor, Dr. Sheshia sir, and Samar Banerjee sir for the excellent talk to start with the conference today. And as we have to thank our mentor, Dr. Sheshia sir, for giving us the Indian solution for the Indian problem. Though we are practicing it almost for more than 10 years, 1 decade we are following it. All the government hospitals are, government of India also endorses of DIPSI guidelines. I am happy to see that NICE guidelines also accepted the same way where we are going in the DIPSI guidelines, and futurely definitely IAD PSG also comes into endorse our DIPSI guidelines in terms of that all the organizations, since we are having puzzle or we are having medal in diagnosing diagnosing the gestation diabetes, the only riddle, the solution we do have, the solution for this riddle we have is the DIPSI guidelines. So hope all the organization will do accept in future to come. And as with Samar Banerjee's talk, these pre-markers are quite complicated, though quite complicated. As I said, and the insulin markers, particularly HOMA-IR and polycystic ovary, these are the era we have to prevent the gestational diabetes in the fetus, so that we can prevent the non-communicable diseases in the future. We are in the evidence, we have a huge evidences how can we prevent NCD, though we cannot able to change the genetic system, but we can do something about the epigenetics by changing the physical lifestyle and changing the diet pattern, and treat them aggressively and pick them early, so that we can prevent diabetes mellitus, so that we can prevent the gestational diabetes mellitus too, so that prevent the diabetes in the future. As our mentor used to say that focus the fetus and prevent the NCDs in the future. Thank you, Hema Madam, for the wonderful opportunity. Is there any questions?
Can we call Dr. Sanjay Gupte? I think he wants to ask some question.
Please.
Dr. Sanjay Gupte, please. Is he logged in or Hema?
He is there, but he has to unmute. Dr. Gupte? He is just giving a profuse compliment to Samarda about his talk. He says, Samarda, very academic talk as usual. Thanks very much. So Sanjay is very much there, and we all echo Dr. Gupte's feedback on your talk, sir. Thank you so much. Dr. Gupte is much into genetics, and he's established a big lab and something to do with microbiomes and epigenetics and molecular something. There's a lot happening in his head and in his lab. That is why he was keen on tapping a few of the things, but I think he's floored by Samarda's lecture, so he's nothing to ask now. Samarda?
Hema, there are 3 questions.
Yeah, Madhuri, please.
If this is from Dr. Om Kumari. How can we decide the dose of metformin in PCOD, and for how many months can we give metformin? And she also has another question, is if patient on PCOD is conceived after taking treatment with metformin and other medicines, how long we should continue metformin in pregnancy?
Okay, these questions will go to Dr. Sadhna Gupta when she addresses in her panel. Is that okay, Sadhna?
There's another one, the percentage of pregnancy wastage is being asked by Dr. Subrata Kumar Gupta.
Yeah, so all of these, are relevant to the panels which are coming up. So we will take that up accordingly. So yeah, so I think yeah, Puri.
Yes.
Okay.
A big thank you to the chairpersons and the speakers for elucidating the current thinking on the NCDs. We now move on to session 2 of day 1 of this today's Congress. So this will be the SAFOG session. And this will be a panel discussion on implementation of GDM care. What is the ground reality in the SAFOG regions? To moderate this session, we have Dr. Sadhana Gupta. The panelists for this session are Professor Narendra Malhotra, Dr. Indu Asanka Jayawardene, Professor Dr. Firdausi Begum, Dr. Piki Saxena, Dr. Yusuf Latif Khan, and Dr. Banshi Sabu. The moderator for this session is Dr. Sadhana Gupta. We have the golden opportunity to invite her today. She is the FOGSI representative to SAFOG 2018 to 20, Vice President FOGSI 2016, FOGSI representative to WHO and UNFPA workshops on postnatal care and achieving MDG, qualitative reproductive child health in adolescents. And she's a recipient of a whopping 9 gold medals in MBBS. Moving on to the panelists today, Professor Dr. Indu Asanka Jayawardene. He is a senior lecturer in obstetrics and gynecology, Faculty of Medicine, University of Colombo, and he's the distinguished guest today all the way from Sri Lanka. He's the honorary consultant obstetrician and gynecologist, University Unit, D. Soisa Hospital for Women and National Hospital, Sri Lanka. He's the member of Board of Study for Sports Medicine, PGIM. Our next panelist today is Professor Firdausi Begum. She is Professor, Department of Obstetrics and Gynecology, BIRDEM General Hospital, Dhaka, Bangladesh, President SAFOG, President-elect OGSB. She's the member Technical Subcommittee for SRH under SEARTAG Women's and Health, Children's Health, WHO, Member Technical Advisory Group, TAG, for Quality Improvement Secretariat, Special Awards and Recognition. She's received quite a few. She's a WHO Fellow, Member FIGO Committee for Guideline for Intrapartum Fetal Monitoring. The next panelist today is Dr. Piki Saxena. She's the Professor of Obstetrics and Gynecology, Lady Hardinge Medical College and SSKH, New Delhi. She has published more than 150 articles and has given more than 100 clinical talks. Research and strength unparalleled. She is the General Secretary of Board of Management of Delhi Diabetic Forum, member of Drug Controller General of India, Subject Expert Committee, Reproductive and Urology. She's a Senior Executive Editor, Indian Journal of Medical and Specialties and Pan-Asian Journal of OBS and GYN, and editor of DDF Journal and Newsletter. Science has no boundaries, so our next guest will be from Pakistan, Dr. Yusuf Latif Khan, Professor of Obstetrics and Gynecology in Rashid Latif Medical College. He's a most active member of ART team at Life Clinic, Hamid Latif Hospital, Scientific Secretary, IVF Society of Pakistan, General Secretary, founder member of Society of Gynecological Endoscopy, SGE. Last but not the least is Dr. Banshi Sabu, who is the only diabetologist on the panel today. He is the president of the Research Society for Study of Diabetes in India 2019-20, president of the Indian Obesity Society 2016-20, honorary secretary of Diabetes in Asia Study Group, honorary secretary of Diabetes India. He has awarded most impactful healthcare leaders by World Health and Wellness Congress Awards. I would like now to hand over to Dr. Sadhana Gupta to carry on with the panel discussion. Dr. Sadhana Gupta, ma'am.
Thank you, Dr. Rita, and allow me to share the screen, and with hearty thanks to Dr. Hema Divakar, SIDP and artists for this wonderful opportunity to moderate the panel on the ground realities in SAFOG region. And actually with the Dr. Sheshia puzzle, muddle and riddle, and the futuristic lecture of Dr. Samar Banerjee, we are here ground realities, what is problems, what is issues in South Asia. I bring greeting from FOGSI, SAFOG and ICOJ and welcome all the esteemed panelists. So South Asia, we are one, I think we are emotionally by race, by culture, by emotional we are all one, and are we prone to diabetic as a race? Or it is a result of sharp change in lifestyle and environment which has created epigenetic change? This is a big question because 10 to 15 years ago, around 2013, when Dr. Hema Divakar took this diabetes in pregnancy with a very loud voice, I was also skeptical whether it is a real problem or not. And now it is around the corner and can be anywhere in our obstetrical population. It is an important public health issue, and beyond perinatal implication, GDM marks beginning of vicious cycle. What the Dr. Samir and everybody was talking, that diabetes begets diabetes, leaving a legacy for both affected mother as well as her offspring to face long term. So it is a public health issue, and it is tsunami of diabetes. It is all what is impaired gestational glucose tolerance, which is, and the use of term gestational has been actually encouraged to communicate that the pregnant woman needs a very careful surveillance. However, FIGO recommends term hyperglycemia in pregnancy for all set of impaired glucose tolerance in pregnancy. So what is the issue? We have Dr. Banshi Sabu, of course, as a diabetologist, because we have to work together with physician, we have to work together with endocrinologists, because it is considered, GDM is considered to be at the intersection of the two major areas of health, that is maternal and child health and non-communicable disease. And in SAFOG area, reproductive and child health and non-communicable disease, both are a big issue, and we have to focus on these three issues. And if we really manage GDM well, it will determine pregnancy outcome as well as accompanying the opportunity of preventing type 2 diabetes. So we have joined the hands and coming to ground realities in South Asia. So I will take this question to Dr. Fardausi Begum and Dr. Yusuf Latif Khan, that in Bangladesh and Pakistan, in last 5 to 10 years, incidence of GDM is same or it is on rise or decline, and how much of percent of obstetric population is being confirmed for GDM and its management accordingly, and whether it is a divide between high or low socioeconomical or rural urban class. So we will first Dr. Fardausi Begum and Dr. Yusuf Latif Khan to have the inputs from your country. What is the situation over there before we coming to Indian situation? Dr. Fardausi, please.
Thank you so much. This GDM and hyperglycemia in pregnancy is a really botheration for us, because we have to take it seriously for the maternal and fetal reason, especially perinatal outcome. So in Bangladesh, the statistics varies. I was just going through a meta-analysis, and that meta-analysis say that in Bangladesh it is 8.2%, and the very 95% confidence interval is 6 to 16, something like that. But in the data we use in Bangladesh is around 13% of the pregnancy is GDM. And basically, there is no such data to tell us that the incidence is increasing or decreasing. But the lifestyle change, of course, says us that there is a tendency to increase. And there is, of course, urban-rural variation. It is more in urban population than in rural population. So that's the circumstances in Bangladesh. And as in most of the countries of South Asian region, Bangladesh is also a very high risk area like India. So the recommendation is for universal screening from the very beginning, because the load is quite high, around 13% is not a matter of joke. So we take it quite seriously.
Thank you. I think this slide, this recent data also echoes your statement. And Dr. Yusuf, your input in the area of in Pakistan, what's the incidence you perceive in for GDM? Dr. Yusuf? Dr. Yusuf, are you here? Are you here? I'm seeing Dr. Yusuf. So what is it in Asia? It is average 10.9% as compared to Western world where it is 3 to 5%. And International Diabetic Federation now estimates that 16.2% of women with loved ones had some form of hyperglycemia in pregnancy in the future. So the magnitude is quite high, as suggested by Dr. Fardausi Begum, as well as it is the Dr. Sheshaiah paper, which says that it is quite high. It may range from 10% to 17.8%. And the Sri Lanka prevalence, Dr. Indu Ashanka is also with us. Dr. Indu, please, what's your input about your country perspective for GDM? Dr. Indu.
In terms of hyperglycemia in pregnancy, Sri Lanka, where I come from, it's a semi-urban, it's an urban population, but we have data for semi-urban populations as well as rural populations. Sri Lanka has been fortunate in that even as early as 2001, with visionaries like Professor Chandrika Vijayaratne and Dr. Hattotua, people were talking about gestational diabetes way ahead of the world as a problem. So we have data since, well, we were looking at it in terms of universal screening, and we had a cutoff of 140, and we thought of 120 ppbs 2 hours as a control way back in 2001. So our data from 2003 in semi-urban population in Colombo, there were 9% diabetics in the pregnancy group. When we looked at the same area, we looked at same area twice in 2010 and 2016, it had increased from that 9% to 13 and closest is 19%. So the burden is definitely increasing, partly because we are recognizing it more, partly because our lifestyles have changed and we are becoming very sedentary, and our lives have become more sedentary and prone to diabetes. But I think part of this is actually because we are recognizing this a little bit more as well. But since Sri Lanka is fairly in a unique position because it was doing this much longer than even the American or the RCOG, before they recognized that diabetes, gestational diabetes, as a gestational problem that needs attention, people here were talking about universal screening. And fortunately for us, this went through. And when we met in 2016, I was fortunate enough to meet Dr. Sheshaiah and Dr. Balaji in Sri Lanka in 2016. And at that time, Sri Lanka was going ahead with national guidelines.
Report guidelines?
I think this actually, what is Dr. Ashanka, your statement really echoes what professional bodies can achieve. And it was the futuristic vision of the Sri Lankan OB-GYN associations. And we can say from the FOXY and as a SIDP that we are having our own problems and we are not like following the Western world. And that is the great way, and that actually shows the responsibility of the professional organization. Yes, of course, we are having epigenetic life changes, suddenly sedentary lifestyle, suddenly people are also having a variety of food, and there are so many things. Still, there is a divide between urban and rural areas and among the states different area, and that again emphasizes the importance of food and the hard work. Now, with
Dr. Sadhana, there is one more possibility in urban area because of late marriages, and maybe that is also one of the reasons that increasing GDM incidence in an urban area. If you see the age of the marriage and getting the pregnancy, which we are seeing that in urban and rural area, there is a significant difference. It's almost like 5 years. And that could be also reason. But other than that, increasing obesity, we are recognizing more. Maybe in urban area, the awareness about the GDM is more. So these may be the multiple reasons why we are getting more GDM.
Thank you for bringing out this point also, because of course the age contributes a lot about this, about the GDM. So coming from
Dr. Sadhana, can I add something?
Yes,
what,
yes.
what we observe in the meta-analysis that in our region, Nepal has the lowest incidence of diabetes. So their rate is about 1.5% and ranging from 0.2 to 3.2%. So I think that's the physical exercise, maybe the strain, the lifestyle maybe have some factors as well, which can be depicted by the Nepal figure. Thank you.
Yes, so if I add just one more message that I'd like to add. I think being South Asians just puts us in a significant risk by being South Asian itself. If we are going forward to control this epidemic, one thing we have to realize is that we need to go for universal screening, that we have to offer this screening for each and every woman coming to the clinic, irrespective of their obesity status, age, because we have proven once and again, when Dr. Seshaya spoke about this, how to screen people, we need to do universal screening. We can't.
That is the point, Dr. Ashanka. Dr. Fardausi Begum has rightly said that we have to be hard as a South Asian. We cannot afford to go only on mobile and do all sedentary work. And what's your comment is that to detect it, but to prevent it, we have to retain our hard working habits and having healthy.
Absolutely.
So coming to Dr. Ashanka, you have already set the stage for the screening, and we have Dr. Seshaya and Dr. Hema Divakar with us, who have actually done a good research and presented the data to world about own DIPSI studies and which is workable in South Asian population. Now, screening is it is a puzzle, muddle and riddle, what Dr. Seshaya says. So my question, we will start from Dr. P.K. Saxena, who is working as a research person as well as in the public hospital, that when we have the contact with the antenatal woman, what is the period when you offer a screen? It is in first trimester, first and late second trimester both, and first, second and third trimester. And the second thing is, how do you screen? Because there is a lot of issues and lot of question mark on various tests. So we will start from Dr. P.K. Saxena and then we go to Yusuf and finally to Dr. Banshi Sabu for his final remarks. So Dr. P.K., what do you do in your setup to detect GDM? At what time repeat, and how do you do? Dr. P.K., please. Dr. P.K., Dr. P.K.?
Yeah, am I audible now?
Yes.
Yeah, Dr. Sadhna, in our setup, we understand the high risk of the Asian women. And in the first visit, even if she comes in the first trimester, we do a DIPSI test. And we have a very nice setup. As soon as the woman walks in, we have the government supplied 75 gram anhydrous glucose available. The woman is given a glass and a bottle and she drinks it up there. And by the time her ANC is done, all the antenatal examination is done, we have a marking of 2 grams. After 2 hours, we have the DIPSI test report. So if that comes okay, if we are detecting in the same visit whether the woman has GDM or not. And if it is coming very high or very low, we sometimes repeat it with the venous sample. And we, of course, repeat it in the second trimester between 24 to 28 weeks. And only in high-risk patients who are obese, having gestational hypertension, and other high-risk family history, big baby in the previous pregnancy, we do it in the third trimester. Otherwise, we are following the same MOHFW criteria. And another thing I would like to point out is that we have ourselves done big studies on 1,000 women and 800 antenatal women. And again, I'm a strong proponent of DIPSI, because with IADPSG, when we compared, and we also did another study in which we compared with WHO 1999, and the third study with Carpenter-Couston, which have also been published, the DIPSI was in congruence and 98% as efficacious as the other methods. So I think especially in the COVID era, when the European countries are propagating fasting levels, fasting blood sugars, HbA1c, I think our DIPSI is the best. So only one visit, very less time to be spent, and very economic.
So thank you very much.
Especially with the plasma glucometer.
Thank you very much. That was wonderful sharing of experience. And we will now move to Dr. Fardausi Begum. What is situation in Bangladesh? And if Dr. Yusuf has been audible, I think he was there. What you are doing as a screening test in Bangladesh and Pakistan?
Sadhnaji, Narendra has also joined and Yusuf is also here. Yeah.
Now Dr. Narendra has joined.
Yeah, Narendra has joined. So let me, because I told you, Sadhna, I need to leave. So I'll just quickly go through this, and I have to be excused. So basically in Bangladesh, we are following the International Diabetic Association, the method of screening. So we go for fasting, 75 gram glucose, and address with 250 ml, and then 2 hour sample of the fasting is 5.1 and 8.5. So that's our cutoff value we follow in Bangladesh.
So you do.
So there, there are.
Yes. Please go ahead.
Yes. So basically we offer in the first trimester, and when the nausea vomiting is a bit subsided, so we do this screening, and if this is negative, then we offer them in the second trimester, and that is negative, we offer in the third trimester, because we're a high risk population. So that's the screening method there. And we must do it in our guideline. We must do at least 1 hemoglobin A1C level, because there are diabetes in pregnancy is not a very simple thing to deal with. So there are so many depending factor on which this perinatal outcome and maternal outcome varies. So there are different studies as well, that even hemoglobin A1C level in uncontrolled in first trimester, second trimester, third trimester, that has some implications as well. So yes, DIPSI is a very simple test. I also sometimes for screening and say mass screening sort of detection of prevalence, we advocate, but clinicians, especially our endocrinologists, we are still for this IAD PS test, so that so that's our national policy. So thank you for this.
Thank you, Dr. Fardausi, because it brings up a very important thing, that you are taking 2 samples and still not doing DIPSI as a routine test, because there is always issue that the pregnant woman can be, how she can be on fast value.
Also the venous test and the capillary blood, that has also some implications.
Yes.
Thank you so much. Yeah.
So thank you very much, Dr. Fardausi. If Dr. Yusuf is there, please, what you are doing in Pakistan. Before we go to Dr. Naren Malhotra, he is working in a very big private hospital. And how do you screen in your corporate sort of setup? DIPSI is feasible, or the whole fasting and the 2 hours postprandial, or the total oral glucose tolerance test. So Dr. Yusuf and then Dr. Naren Malhotra, please.
Thank you, Dr. Sadhna. It's good to see you. For inviting us to be on this panel. I hope you can hear me.
Yes, you are here. You are audible.
Okay. I think if we look at all of this scenario, the best place would be kind of screening them before they get pregnant, pre-pregnancy. But unfortunately, I think it's the same scenario in all our SAFA countries, that nobody kind of do that prenatal kind of checkups for the checkups to come in and get them screened out. If that's not been done, then it's probably what we do over here is we divide the patient into, as always, high risk and into a low risk categories. And those who have a history of diabetes, whatever, they need to be kind of checked and monitored at that level. Otherwise, routinely, if a patient is kind of a low risk, we are doing this DIPSI test, 50 gram, not a 75 one, and in the second trimester. And if it comes out to be negative, we kind of do that. But I prefer to have one time, as Dr. Fardausi said, HbA1c also be kind of screened. And it can be easily done in the first trimester as well, just to make sure that they're not. But if there is no kind of risk factors at all, then one time I think this is done. But if there is kind of risk factors which kind of add up, we can do the screening in the first and even in the second at that time. But they have to be diagnosed in doing that.
Thank you, Dr. Yusuf. This was very, very important share. And Dr. Naren Malhotra, in a very highly paid setup or corporate setup, what you do in your practice for the screening of GDM? Because we have already we are finding 3 or 4 methods of doing. Dr. Naren, please.
So very good evening to all of you. It's indeed a pleasure to be on this panel, and greetings to all the CEFOG country representatives who are here, Dr. Sadhna and Dr. Hema. Thank you very much for inviting me to this SIDP. Now, I'm not in a corporate hospital. I am in my own small nursing home, which is a 10-bedded nursing home. The corporate hospital is the part of the gynec part in the big hospital is also similar to this. So anyway, wherever you are, that's beyond the point. The point is that you got to pick up whether the patient is normoglycemic in pregnancy or has insulin glucose intolerance or is diabetic or GDM or diabetic. So this simple test of DIPSI, which is the Diabetic Study Group of India, is 75 grams of anhydrous glucose given anytime, non-fasting, and 2 hours later. If she comes below 100, she's normal. 100 to 120, like maybe intolerance, and 120 to 140 intolerance, and over 140 GDM, over 160, 180, she could be diabetic also. So that is what we follow on the first visit, antenatal visit, whenever they come. Mm-hmm. And if she's not able, because of nausea, vomiting, vomits it out, you can try it again or try it after a few days. And then it is, of course, repeated. If it is negative, it is repeated in the 2nd and the 3rd trimester, because late onset GDM is also need to be looked at. And if it is positive, then they are to be followed as conventional diabetic patients. And that is where you can do either a 6-point glucose test with urine and HbA1c to monitor them. HbA1c we use for monitoring, not for diagnosing. And if they are put on metformin or on insulin, depending on what the diabetologist will plan for them. If they have been PCOS, history of PCO pre-pregnancy, then we would like to, of course, pre-pregnancy counseling. At the time, if they come for pre-pregnancy counseling just after marriage, we would like to do a baseline blood glucose levels at that time also. Fasting and PP and all the other routine tests, and of both the couple, both of them. And then, of course, advise them, give them advice about folic acid, which we call it as the engagement pill. As soon as they get engagement to get married, the engagement pill should be started. And given a good lifestyle. So lifestyle is very important advice to be given to all women who are going to get married and planning pregnancy.
Thank you, Dr. Naren. And a little bit before we sum up this screening issues, HbA1c has been mentioned by many of the panelists, and we will come to Dr. Piki Saxena that what we have gone through, that HbA1c has a very low sensitivity as a screening test for GDM and not recommended as a screening test. And if testing is done without administering a glucose load, which helps borderline glucose intolerance to become morbid, it can miss GDM. So we will have last comment from Dr. Piki Saxena for the use of HbA1c as a screening and what is its role in monitoring, of course, also in the GDM, before we switch on to the another issue of the GDM. Yes, Dr. Piki, please, your input. Dr. Piki. So,
Dr. Piki, you have to unmute.
HbA1c is not very sensitive marker for picking up or diagnosing GDM in during pregnancy, because the RBC turnover in pregnancy is high. There are hemoglobinopathies. Most of the women are having anemia. So it is not considered to be a very good marker. The only use is to do it in the first trimester. So we can pick up women who are having pre-diabetes or overt diabetes. For monitoring, it will give a level for 3 months, which is not very important. We want to know the day-to-day diurnal variations. So that is what is important in controlling macrosomia and other diabetic complications. So it is not, and the other thing is the labs. There are only 2 or 3 labs in Delhi which are accredited to do the HbA1c. So where you are getting it done is also very important.
Yes.
So in our center, we are not getting it done. Only in the first trimester to know whether she is pre-diabetic, we are getting that.
So this is, thank you very much, Piki, for it, that HB1AC is not a good screening tool, and especially in the GDM. And this is our DIPSI recommendation, which shows that it should be done at 16 weeks, and then it should be repeated between 24 to 28 weeks. So we will
Sadhana,
start.
I just want to add one thing.
Yes, yes.
Yes. So one very important that, first of all, I'm very happy that DIPSI criteria and DIPSI screening test is not only used in our country, while neighboring countries are also using it at the same time. But one very important thing, now we are seeing a lot of type 2 diabetic patients in a young age also. And sometimes, which we are seeing is a diabetologist, because we get the patients who are referred to us for hyperglycemia in pregnancy. But at the same time, we get a lot of patients who are already pre-gestational diabetic, and they were actually first time detected diabetes during pregnancy. But still they are given the 75 gram screening test is being done. So my request to all of them that if you find that somebody is at very high risk of developing diabetes, please get the first random blood glucose. It could be 200. It could be occasionally, you may find that person is having already diabetes, and then there is no need to subject them for a screening test for GDM or a hyperglycemia in pregnancy. They could be the persons with already pre-existing diabetes, might have got detected first time during pregnancy.
Thank you very much for bringing out this point. All a very, very valid question, very, very valid point, that if the patient is already having high blood sugar and or she is already having diabetes, please don't put her the extra glucose load. One thing we will say to Dr. Yusuf, when Dr. Yusuf and then Dr. Naren Malhotra, still we do it on the first contact, we repeat in second trimester. Still, in a high risk patient, patient is having previous bad obstetrical history, large size babies, congenitally malformed baby, still the history remains something important to like our screening and monitoring protocol. Dr. Naren Malhotra, if still history has got some importance in our monitoring protocol, or it is no value nowadays? Dr. Naren. Dr. Naren and Dr. Yusuf, anybody can take it.
I mean, you mean screening if the history?
Yes, history. Yes, I mean this.
History is very important. That is the first thing. So history, and if she has a history of diabetes and she has all that problem, that is most important aspect for me. And if she is diabetic, then why are you going to screen? And as it's saying, if she is also suspected to be diabetic, then we can do a random or a fasting sugar first. And it's over 200, then you need not screen. But that is how we follow. So history is very, very important. Yes.
So thank you very much. Still, because we have to take a very good history. And finally, the thing is that this panel also bring out this point that still we don't have a agreement for the universal methodology and universal timing of screening and the single or two-step approach. So this is important. And second thing, which will start from Dr. Bansi Shabu.
Sadhana, 1 minute, make one point. In the COVID times, the Australian guidelines gave so much emphasis to history that they said if a woman has had a previous history of GDM, there is no need for testing. Take her as GDM. So history is one of the most important points.
And that's why I took this question, that as a obstetrician, we have this responsibility. Second thing, we will come to Dr. Bashir and then Dr. Indu Ashankar. Why, if we get in first trimester, we have the GDM values like more than 140. Can we think that it was the pre-gestational diabetes or not GDM? And which is more dangerous, which women require more close monitoring if we detect in first trimester or if we detect in second trimester? Dr. Indu Ashankar. And then, yes.
Thank you. Now, I have the fortune of working in a place where the field midwife work or the field work is excellent. Our booking before 8 weeks rate is about 95%. So anytime I see for the first visit for a patient, it's very likely that I'm seeing her around 12 weeks. And my concern at that time is to check whether she's pre-existing diabetic or not. Unfortunately, our preconception workout doesn't completely exclude the person having diabetes. So about 30% of my diabetic work or the gestational diabetic work relates to people who were diagnosed around 12 weeks. For all of them, I consider them before, if we diagnose at 12 weeks or before, I consider them diabetic until proven otherwise. And I do refer them to the diabetologist after the pregnancy, even if the pregnancy behaves completely normal with control. So my assessment at 12 weeks is to go back and assess an HbA1c to see the control. If that is 7 or more, then she gets automatic referral to the diabetic physician where the renal complications are looked at and she gets an ophthalmic assessment done. And then intensive glucose control is instituted. Our cutoffs, we ask them to do self-blood glucose monitoring. And there's a diabetic nurse who does that for me. And she liaises with the patient. She buys her own.
Dr. Ashanka, we will come for this monitoring. And just I want to emphasize that if we detect first trimester high glucose level, then the fetus is having more risk of congenital malformation. There are more diabetic complications in mother, and there is a need for proper treatment. So this is the difference between first trimester and the second trimester GDM. Now coming to the second question, we will have, I think, 20 minutes more. So the second thing, the second question, you have done DIPSI or you have done screening, and now the glucose challenge test has shown the 156 by DIPSI. So it is 156 in the at the 26th week of pregnancy. So, Dr. Picky, what you do for such women? You are doing a lot of DIPSI tests and you are diagnosing. What you advise for this borderline impaired glucose tolerance for these women? Dr. Picky.
Dr. Sadhana, once we diagnose a woman, we don't do any other tests. We do a 7-point profile, and depending on her blood sugar profile, if it is not very high, I will go for medical nutrition therapy for 2 weeks. The lifestyle changes, telling her properly about how to take the diet, divide it into 3 major meals, 2 to 3 snacks, mid meals, and how to do the carbohydrate counting, the quantity, the quality, and the distribution, low glycemic index diets, complex carbohydrates, all those things, along with exercise.
Yes, I just want to know that you are doing it yourself or you are having a full-fledged dietitian, because Dr. Ashanka says it is a wonderful team that they have the diabetic nurse, they have a diabetic.
No, Dr. Sadhana, we have a dietitian, but we only have to do it practically in a very small time. So we give the concept of the Government of India thali, that is there. Adha thali full of vegetables, cooked and salad, 1/4 protein and 1/4 of cereals, along with 1 portion of fruit and milk or curd. That is how we counsel them, tell them what foods to eat, what not to eat. And according to their socioeconomic strata, their religious and cultural beliefs, we try to give them a individualized this thing. Then we send them to the kitchen, the dietitian who gives them a diet chart. But I'm sorry, they don't do too much of counseling. So I think we have to do that in a practical way.
Thank you for being so realistic and honest. Dr. Yusuf, how do you deal with these, with your patient who is borderline GDM? Were you sent to the diabetologist and leave them away, or you yourself is doing like Dr. Picky is doing? Dr. Yusuf, your experience. Yusuf?
Yeah.
Yes.
Thank you, Dr. Satna. I'm back again. This borderline diabetes, I think my previous speaker has summed it up. The first thing is, of course, the nutritional advice and exercise as well. And the amount of exercise which we generally recommend is them to have about 15 to 30 minutes in the morning and about 15 to 20 minutes time in the evening time. And with all this, one thing we need to do is we need to do an ultrasound also to see the effect of, if there is any effect on the baby as well, of macrosomia and polyhydromias. If there is effect on the polyhydromias and if we are macrosomia, then of course we kind of intervene earlier, manage it earlier. But if there is no effect, we'll review her again after 2 weeks' time and then decide about how to go about it.
So thank you very much. I think for most of us, we have to do our own like counseling, and we have to ourselves should be knowledgeable about it, and exercise and all this thing has to be like counseled by obstetrician and gynecologist, and if you have a good team, then it is better. Now the patient has been prescribed all medical nutrition and change in lifestyle, and still her blood sugar is sometimes 150, 160, occasionally 180 to 200. So now this is the time to start pharmacotherapy, and we will start from Dr. Banshi Sabu, that what do you think that we should send to you, your fraternity, or we can start our own? And the second thing is, what is the role of, we have certainly one question that oral hypoglycemic agent, anybody can start, or we should think of insulin for a proper control in GDM especially. Dr. Banshi Sabu.
Yes, so first of all, thanks Dr. Sadhna for very nicely moderating the complete session and involving all panelists at right time. And the first previous question which you had asked, that if you are getting a diabetes in the first trimester and you are getting a diabetes or the hyperglycemia in pregnancy, I will not say diabetes, I'm sorry for that using the word, hyperglycemia in the second or third trimester, how they are different. So from the diabetologist point of view, the person who is getting hyperglycemia in first trimester, there is a possibility they are pre-gestational diabetes. They could be first time detected diabetes at the pregnancy also. Other than the obstetric complication, as we know that even at the time of diagnosis of diabetes itself, we know from UKPDS data that 25% of them may have a complication of type 2 diabetes itself. So they may have dyslipidemia, they may have microvascular complication, they may have retinopathy. So they require more aggressive monitoring. So one thing is very clear, if you are getting hyperglycemia in the first trimester, I think the role of diabetologist and endocrinologist involving in that particular case earliest possible is very, very useful. Not from obstetric complication point of view, not from sugar control point of view, but also for looking for other complication which she may have. We don't know, because now we are seeing a 37-year-old female who is coming to us by a infertility specialist, and then she was already having a diabetes even her 6 weeks or even at 4 weeks. So I mean, they may have other micro and macrovascular complication. That's number one. The second part, you are saying that what should be the pharmacotherapy who is detected hyperglycemia in pregnancy. So that as the doctor or a diabetologist, why we should involve them as early as possible. One thing which is very important, they should be involved because the person with diabetes or the GDM or with the hyperglycemia in pregnancy, they will start understanding the importance of this hyperglycemia. That, you know, my obstetrician had sent to one more doctor just to understand the glucose, which is slightly high. Even it is not very high, because their other brother or sister, they might be having even 250 and they are not visiting the doctor regularly. But now my obstetrician is sending to another doctor. It means it is something which is very serious. I have to take care of myself. I have to take care for my baby. So this, for just seriousness, if you just refer to a diabetologist fraternity, that itself will increase the compliance of the patient, because then they will understand that nutrition counseling which you have done, which will be again reinforced by the diabetologist. Probably even we are not starting any pharmacotherapy, because 50% of the patient, they may get good control by a nutritional counseling itself. That itself will get reinforced. They will understand the importance of a tighter glycemic control, and very important, the self-monitoring of blood glucose. Probably what I had seen, the monitoring which you tell, and when the patient goes to, again, I mean, I will not say patient, because a person with hyperglycemia in pregnancy, if they go to a diabetologist, then the things will change, because they start monitoring themselves more regularly. They understand the importance of hyperglycemia. If it is post-meal glucose level, even after a good control of diet, still it controls comes up more than 130, they should be started with insulin. And insulin is the choice, but metformin can be used. I know. So that's a very important question.
So your choice is, yes, this is very, very important. What is your choice? choice, insulin or the metformin or glyburide? And then we will go to Dr. Narendra.
Glyburide, so you forget. I don't see that we should talk about the glyburide. Even there are some data, but it causes more hypoglycemia. It is not going to be used. The monitoring will become more difficult, and then it can create more problem. Metformin can be used as a pathophysiological agent because primarily somebody is getting a hyperglycemia in pregnancy or a type 2 diabetes. So it's an insulin resistance followed by, some sort of a beta cell dysfunction. So that's how it can be used. But now the data with the first trimester use, the data is not so much, lucrative. And the second trimester you may use. So insulin becomes, the choice of therapy by the diabetologist, and then to start the insulin and to monitor the regular follow-up of the patients who are on insulin and to give them insulin in a proper dosing. I think a diabetologist entry makes sense. There are 50% of the patient where nutritional counseling is enough, but still that nutritional counseling can be reinforced by your colleague who is a physician, who is a diabetologist, who is an endocrinologist. I think it will make sense.
Thank you, Dr. Banshi. It was very good and very clear. And DIPSI also still has not advocated the use of oral antidiabetic for glycemic management during pregnancy. We have one quick comment from Dr. Naren Malhotra about the use of oral hypoglycemic agent in GDM.
He left. He has already written in chat box. He left already.
Okay. So, Dr. Piki, we will come to you. That are you using oral hypoglycemic agent or only insulin is your choice?
Insulin is the only choice. And I would also like to emphasize on this forum that metformin is not approved by any regulatory body all around the world, by the European Union, by the FDA, by the Drug Controller General of India, or by the Australian Union. So, and all guidelines, the ADA and the ACOG say that as it crosses through the placenta, we need counsel the parents that it crosses through the placenta, and we are not very sure about the safety efficacy in a long term. So, and insulin is the drug which is going to be used in 33% patients who are not going to get controlled on metformin during labor, any complication. So it is better to start only with insulin and continue.
Thank you very much. I'm very happy for having.
Bansi, can I say something? Bansi, Ashok here. Bansi, can I say something?
Yes.
Madam,
yes.
I just want to say that what Dr. Piki Saxena said is true. But madam, there are urgencies where people do not take insulin. They outright deny. So the treatment of GDM and pregnancy, diabetic marching through pregnancy, as you rightly said, the first choice, second choice, third choice, fourth choice is insulin. But if the person is not going to take insulin, an inferior choice is oral hypoglycemic. And out of oral hypoglycemic, including sulfonylurea, metformin has got some evidence to back it. The importance was the MIG study. Madam, I should not carry cold to Newcastle, MIG MIG study, metformin in GDM study, which was by Dr. Owen. And Dr. Owen showed in about 1,000 patients that metformin is safe. In them, as you rightly said, a small portion, 30% will only need insulin. Rest can be controlled by the nutritional advice and lifestyle modifications. Out of this 30% who needed insulin, if they don't take, when they were giving metformin, he found that in about 40% cases, he had to convince them and add a small dose of insulin. And he has shown, as you rightly said, the long-term data is not available. The TOFU study, what is going to the offspring of the not yet available. But madam, I must say that in our country also, there is no DCG approval yet. We have put the application, it may not come through. But the government of India has said that if you do not have any other means, you cannot convince sugars are remaining high, metformin can be given. Bansi bhai, I would again like to add one more thing, that if there is a diabetes, a non-diabetic marching through pregnancy, if she is already on insulin, we continue the insulin. I'll come to my presentation. But sometimes, if the fasting is very high, you cannot control with multiple small dose plain insulin. We are after 16 weeks, not before 16 weeks, as you rightly said, madam, after 16 weeks, we add metformin, and this is continued throughout pregnancy. I'll repeat, it continued intrapartum, postpartum, it's continued. Now, there are few benefits of metformin, which Hema has taught us.
So So thank you very much. I think we will have a one session also, and this is the ground realities. And thank you for your valuable input. The insulin is the drug of choice, and metformin is
absolutely, Dr. Sadhana. Absolutely.
In certain select situations. One thing, a quick review that we will again come to Dr. Banshi, that how tight is too tight, and what you think if the patient is on insulin, this is 3 times monitoring, 2 times or once a week or twice a week, before we go into some obstetrical issues with the Dr. Banshi, how close monitoring you advocate to your patient with the GDM?
So actually, I am getting the patients who are very high risk. I get the patients from infertility specialists. Every day we are seeing almost with more than 4 or 5 patients with GDM. So I mean, it's already a high risk, and they are very, the precious baby, you can say like a 37-year-old first time becoming pregnant and 42-year-old. So I mean, I do very, very strict monitoring for these persons, but that is not to be recommended for everyone. That is what I want to tell you. So the strict monitoring means we are telling them to monitor more than 4 times. We are having the patients who are on continuous glucose monitoring. We have a big data list of existing type 1 and type 2 diabetes who becoming pregnant.
Sorry, I would like to interrupt here.
Yes, sir, please.
Yes,
so,
sir.
Please, I don't know. I am very, very concerned about that. Blood sugar fasting should
90,
not 95. Because 95 is American guidelines, not Indian guidelines. And the Americans are stupid fellows. I'm sorry for the word, because I'm very harsh. Diagnosis 92, Sadhana. GDM is 92. How can you control 95?
Yes.
Is it logic?
Yes.
It's not logic. When you diagnose 92, how can you keep 95 for a control?
What Sir is telling, Sadhana, is a very important point. When diagnosis is at 92, even by IADPG, the fasting, and we cannot make it 95. But sir, I will beg your excuse that the guidelines which were made in 16, actually it was made in 14, 15, published in 17, had by mistake this 95. Now we have resubmitted the paper where 95 everywhere has been removed. You might remember, sir, this 95 was the bone of contention between us, you and me, and some of the doctors who came from some other institute. Remember, sir, Delhi meeting? And after that, the government of India accept only 90. But sir, some papers are not yet corrected. I fully agree with you. Some people also write 92. That also we have changed to 90 now. So you will find that in some presentations, people have said 95, but that is old, sir. Even in this consensus which we published about 2014, it was by mistake 95.
So now anyway, we can say that we need a good control. I think we should not muzzle up on too much on 95 or 100. One point with Dr. Bashir saying, and I am working a lot of rural patients I am having with the GDM, and what I believe that if we really teach them for the self-glucose monitoring, they do it. They also follow the insulin administration, and we have to believe in the people. So this is very important. And now coming to Dr. Pitti, that how the maternal and fetal surveillance should be there for the GDM. About the obstetric issue, when a patient on GDM, she is well controlled with the help of dietitian, with the help of diabetologist, and with the help of your effort. But what message you give to obstetrician that how these GDM patients should be beyond sugar level should be followed up for the maternal complication as well as the fetal surveillance? Dr. Pitti.
So Dr. Sadhana, we all agree to it that this is a high-risk pregnancy. So we have 2 categories of patients. Women who are controlled on medical nutrition therapy, they are group 1, and 90% of them, of the GDM women, are controlled on medical nutrition therapy. In those women, we just follow the protocol of the high-risk pregnancy. There is no need to do too many extra tests, too much of fetal surveillance. While in the group who are having overt diabetes or are GDM on insulin or oral hypoglycemics, in those women, we need to do a more intensive monitoring. Ultrasound should be done every 3 weekly, not before that, because we are doing it for biometry to rule out macrosomia and the amount of liquor. we need to have a very close monitoring for blood pressure, because most of these women are going to develop hypertensive. They are either chronic hypertension or preeclampsia or superimposed preeclampsia. So if we find a high-risk woman, PCOS, or having high-risk familial factors or previous pregnancy, we should start with aspirin, I think, at 12 weeks to prevent preeclampsia, and it will go a long way. And otherwise, generally, we do daily fetal monitoring count. We put the woman on daily fetal monitoring count, NST twice a week, and biophysical profile. Doppler is not very much needed unless she has fetal growth retardation in women with overt diabetes or having preeclampsia or hypertensive disorders. So too much of monitoring should also be avoided.
Thank you very much, Vicky, for bringing out wonderful points and the so many color Dopplers if the patient
thyroid also we need to do a thyroid test also, because many of them are having this, and we also need to do a follow these women with UTI. Many of them are going to develop preterm labor and all. So we need to have a close supervision of any genital infection, any urinary tract infection.
What about the diabetic ketoacidosis and hypoglycemia? Why I put this slide? Because both can be the life-threatening situation, and we must know that in pregnancy, the diabetic ketoacidosis can occur at a very low blood sugar level, maybe around 180, and we have to be careful that patient is not having hyperemesis, infection, non-compliance. Sometimes we give steroid. That is the important point adjunctor, and we have to be very careful, and we should be able to manage initially, at least, that we should suspect that it can be diabetic ketoacidosis, and we should start with normal saline and insulin, and then we take the advice of specialists. Because hypoglycemia, I have really faced 2 or 3 situations. Patient comes walking in and her blood sugar is 500, and suddenly patient collapses and patient have the respiratory disturbance. So this is just for saving mothers in diabetic endocrinopathy. This is very, very important that all obstetricians must know. It is malaise, hypotension, hyperglycemia, dehydration, and the patient a typical look, and we have to have this basic knowledge about managing diabetic ketoacidosis. I think Pinky, you have already covered few things, that ultrasound 3 weekly, not more than that, and not very, very close monitoring in the patient on MNT. And if the patient
ECO is also not required for all women with GDM. Only diabetes, if there is a soft marker, or you find that the woman has had a previous history of baby with heart disease, or she herself has congenital heart disease, only then. Otherwise, it is not required in all GDM pregnancies.
So that is very important, because there is issue of availability, first of all, expertise, and secondly, the time. And when we put the things too difficult, and everybody is puzzled and everybody is confused. So that is very, very important. It is a ground reality that we should be very careful about using our resources, and whatever it is, human or it is monetary or what it. So thank you very much bringing out these points, Picky. And Dr. Yusuf, you want to add something about fetal surveillance in your country in the GDM patient? Dr. Yusuf, we will like to have your inputs. Dr. Yusuf, you are there? So we will go ahead with this thing, and now we will say, I think we have only a few minutes left. Now the second thing is, again obstetrician point of view, that the patient is having okay blood sugar level, and now she is 37 weeks, gestational age, 3.8 kg baby. So this is the way, again important, you want to induce at 37, 38, 39 weeks. What is your threshold for doing the elective cesarean section for the fetal weight, and how do you manage obstetrically these patients? So we will start from the Dr. Ashanka and then Dr. Picky. Dr. Ashanka, what you do in your country?
In terms of estimated fetal weight and advising, I think a 4.5 as advised by most guidelines is far too heavy for our women, and any person who has a estimated weight of 4 kilos or more, we would advise an elective cesarean section. We also would consider consider certain facts like her past obstetric history. Obviously, if she has delivered quite large babies without problem previously, then we have to modify our advice accordingly, as well as the fact whether she was having good control or not. Clearly, our main concern would be to prevention of the shoulder dystocia, which is partly weight itself, but partly about the diabetic control, because of the baby's not only the size but relative size of the shoulders and the baby is different if you have uncontrolled diabetes. So all these factors would need to weigh in. They actually get an admission at 37 weeks purely for the discussion and planning of the delivery, and that's done as an inpatient in my university setup. I believe that's slightly too much to have an admission just to get this done, but that actually prevents lots of problems, because when you get a patient admitted, there's the significant concern and a good consensus can be brought in. So they do get an admission at 36 weeks.
I think Sadhana Gupta's internet has
stuff.
Yeah, Vicky?
So in our setup, we generally, although the recommendations say that you can continue the pregnancy till 40 weeks or 41 weeks, in our setup, in a government setup, we generally try to terminate the pregnancy by 39 weeks. And as all the ultrasound markers and clinical examination, they are not very accurate to detect macrosomia. We generally do a feto-pelvic disproportion and then only decide. If it's a big lady, well-built lady, and she has had a previous history of delivering a 4 kg baby, we give them a full this thing to undergo a vaginal delivery. Otherwise, if it's a smaller woman, smaller physique, CPD is there, then 3.5 basically we are taking the threshold as described by Dr. Seshaya in one of the papers. But if the woman is well built and has a good pelvis, good previous deliveries of big size babies, then we may leave the woman also. And if the woman is on insulin, and then we generally try to terminate by about between 38 to 39 weeks. And if she has other complications like preeclampsia or hypertensive problems or any other, then we may deliver by 38 weeks, 37 weeks.
Vicky, one small comment and a question also, because our Sri Lankan colleague said, we think it's ideal to admit all the patients at 36 weeks, because once they're in, then we can, think it through and then, properly figure out how to manage, etc. With 5 million pregnant women per year with hyperglycemia in pregnancy, a whole lot of them will be at 36 weeks with varying degrees of control. How practical do you think is that in our country?
So we don't have those many beds, and I think there is no need if the woman is, if we are monitoring the woman carefully, every week we are following up after 36 weeks. And if the blood sugars are fine, the ultrasonography is fine, the fetal monitoring is fine, then we admit the patient only one or, especially in the COVID times, we get a COVID testing done and admit at 39 weeks when we are thinking of terminating. There is, in our setup, there is no question of admitting the woman at 36 weeks. It will waste, it is not cost effective and it is not practically feasible.
Vicky, one more
Although Banshi ji wanted to make a comment. Banshi, please.
I just want to make the comment only this, that it should not be like that a person with diabetes or a hyperglycemia in pregnancy should not become the rule that all of them should get a cesarean section. They should be given a fair chance of normal delivery. The diabetes should not be a contraindication for a normal delivery. As you were saying that regarding the ultrasounds and the regular monitoring. But what we are seeing in our clinical practice, and being a diabetologist, because we get a lot of hyperglycemia in pregnancy, these persons when they are coming to us and they get normally cesarean section, or they are told that on 37 week or 38 weeks it is already been given because you are diabetic, and we always try to talk to our obstetric colleague that please don't do, you can have a normal delivery, and the child weight inside as per sonography is even 3 kg, and please don't do it premature delivery, give them fair chance, and sugar is not the reason if it is well controlled and if you don't find any other complication. So I personally request Rather Foxy and all of you that this should be a message for all the practicing obstetrician, that those who have hyperglycemia in pregnancy, please don't make the rule that cesarean is the only choice for them. They can have a normal delivery also.
Definitely. Very right.
But it's
in our hospital, we are generally...
Sadhana, you have to unmute yourself.
So one important thing, Vicky, what I see in our all this thing, all obstetrician, that we have the fear of sudden unexplained stillbirth. One important thing. Secondly is the intrapartum complication, that suddenly what happens, and what is your takeaway that when we should what are the situations when we think that this patient can have a sudden blood sugar levels or intrauterine growth retardation, that we should be a little careful about tailoring that this patient need early delivery and this patient doesn't need. So Picky, your message to all, because we all fear that suddenly there will be unexplained stillbirth and we will have all intrapartum complication and all efforts get lost. Picky, your message.
So one history is that if she has had a previous stillbirth, a full-time stillbirth or stillbirth at 36 weeks, that is a very, very high risk thing. Then other thing is if she has uncontrolled diabetes or a diabetes which is controlled on very high blood sugar levels. Along with that, she has IHCP. What I'm seeing, Dr. Sadhana, that these days the women with GDM or diabetes are having IHCP very, very frequently. And if her blood pressure is very high and there is some other obstetric complication, then probably I would like to terminate the pregnancy by 37 or 38 weeks. Even earlier, we give them we admit them, give them dexamethasone for lung maturity, and then offer a cesarean. Women who are type 1 diabetes, who and precious pregnancy, like sir was referring the IVF conceived pregnancies. In all those women, we have to be very, very careful because stillbirths occur idiopathic and because of electrolyte imbalance, because of uncontrolled sugars, and because of the placental maturity, villus edema, all those factors that we understand. So we have to be very, very careful in those things, and we don't take a chance beyond 37, 38 weeks.
Yes, thank you very much for bringing out all the concerns, because we have to take the picture in toto. What is the total profile? Associated hypertension, associated intrauterine growth retardation, what you say, intrahepatic cholestasis, and we should take the decision accordingly. Again, what we said, Dr. Banshi has said that cesarean section is not the indication for diabetic, but it is important. Picky, when you do, when we do patient put on the label, how do you control the sugar level in labor, in the labor process, because that is very important for the neonatological point of view, and we are all concerned now for the neonate. So what's your takeaway, what you do in your labor room?
Yeah, Sadhana ji, you'll have to fast track this last set of questions. Yeah.
Okay. So we are coming to delivery, and
we have to keep the threshold during intrapartum between 70 to 126. And what we do is, if most of the women who are on medical nutrition therapy, we do a blood sugar charting 2 to 4 hourly. And there is no need to add insulin drip or anything, because the requirement, they are using a lot of glucose during active labor. In the first stage, we allow them to take oral fluids, clear fluids. In the second stage, in the active stage of labor, we monitor the blood sugars, the urine ketones, and only if the woman is type 1, type 2 or GDM on insulin, we do put a insulin drip. In normal saline, we will put insulin and we give it till 120. We don't give any insulin drip. If it is between 120 to 140, we add 2 units. 140 to 160, we add 4 units. and beyond 180 we add 8 units. So in that way we monitor so that the blood glucose is between 70 to 126. And in women who are on insulin, we monitor the blood sugar every hour. That is very important. The night before the insulin dose is given fully, in the morning of induction or when the patient is in active labor, we withhold the morning dose of insulin or oral hypoglycemics, and we send a fasting blood sugar and an electrolyte level. If she's for cesarean, we try to post her as the first case. If it is getting delayed, we start a drip, and in the insulin, we give a NPH, the intermediate acting, in 1/3 of doses. And we titrate the insulin drip for keeping the blood sugars between 70 to 126, because at this time, it is very prone that the baby may become hypoglycemic, or she may have hypoglycemia or ketoacidosis, because a lot of steroids are being generated. She is very anxious. Cortisols are being generated. So this is a very sensitive period, and we have to monitor the progress of labor without doing too much of PVs. You know, the residents in the labor room are continuously doing PV. So we keep on telling them that you have to monitor per-abdominally, because they are more prone for infections. And if it is tardy labor, the consultant comes in and they takes a decision, early decision for cesarean.
Thank you very much. Thank you. To be very, very clear that the intrapartum blood sugar levels are very, very important, and our target should be 80 to 110. And we have to be careful about infection, febrile morbidity, and all the things why we have a little or more higher incidence of cesarean section, because few unpredictable situations like shoulder dystocia, birth injuries, or increased instrumental delivery and PPH and febrile morbidity.
Interrupter, but we need to keep on time schedule.
So we are coming out tip for postpartum care. Don't leave the patient. After we will just summarize with all permission of all the panelists that there is a sharp fall in insulin requirement. Be vigilant for the sugar level. There can be hypoglycemia. GDM on MNT can resume to normal diet postpartum. Early breastfeeding is encouraged. Be vigilant for wound infection. And neonatal should be in a close watch for hypoglycemia, electrolytes. For this neonate, we have done so many things, and we should be very, very careful about the neonatal thing. And last takeaway from, I think, if there is Dr. Ashanka, or one thing, what is your postpartum advice when you give the goodbye gift to this patient who has delivered and have a healthy baby? What to do in between pregnancy so that we don't have the final result, that is high incidence of type 2 diabetes mellitus in South Asia. So your takeaway, and before, so we sum up. So it has been already
one good thing that we are seeing in our setup is actually we've started looking at 4 years to 5 years follow-up data. And what we find is that people who followed up and had good control are actually doing as good as, or even slightly better than the normal population in terms of weight gain, their health, and maintaining the healthy diet and lifestyle exercise advice. So what you do in terms of all this gestational time, because people or women are very, very perceptive and very receivable for advice and lifestyle modifications when they are pregnant. So what you do in pregnancy actually do carry on, and you can actually see sometimes they don't have gestational diabetes the next time, and they're perfectly fine. And that's very heartwarming and nice to see.
Thank you very much. So we conclude this thing with a good, very, very positive note. Dr. Jayavardhane says that patient might not have the GDM because as an obstetrician, as a diabetologist, we have trained them well. So that is the crux, which is the aim of SIDP and FOXY and all the professional body association. Thank you all the panelists for wonderful input, and thank you once again, Dr. Hema Devakar, artist, and SIDP for giving this wonderful opportunity. Thank you very much, and a little bit extra time. Thank you.
Thank you, everybody. Thank you, the moderator and the panelists, for the wonderful panel discussion. And it gives me immense pleasure to announce that there are more than 2,200 delegates benefiting from these wonderful, excellent insights into gestational diabetes. And now we move on to the special session of the day, wherein we will address the ground realities in low middle income countries. So to chair this session, we have Dr. Nandita Palshetkar and Dr. Banshi Sabu. Dr. Nandita Palshetkar is the president AMOGS from 2020 to 2022. She was the president FOXI from 2019 to 2020, president MOGS in 2016, and president IAGE in 2017. She has been practicing infertility for the last more than 25 years and is a director at 9 Bloom IVF centers. And Dr. Banshi Sabu, we welcome you once again to chair this session, sir. We have as our speaker an eminent and senior faculty, Dr. Ashok Kumar Das, who will be deliberating on the use of insulin during pregnancy in the low middle income groups. Dr. Ashok Kumar Das is a consultant physician and endocrinologist at PIMS. He's the former professor and head of endocrinology, JIPMER Pondicherry, former director, Indian Institute of Diabetes, Trivandrum, past national president, Association of Physicians of India, Research Society for the Study of Diabetes in India, Diabetes and Pregnancy Society of India, and has been the past dean of Indian College of Physicians. He has overseas experience at London and Sweden. So over to the chairpersons now.
So first of
Thank
all,
you.
thanks Rita for giving us opportunity to introduce Dr. Ashok Das. We have very well introduced Professor A.K. Das. He's a teacher, very respected person in the field of diabetes and endocrinology. He is currently also the patron of our RSSDA society. So that was not written in that particular CV. That's the reason I must tell that it is he's a patron of RSSDI, and he's a very eminent speaker in field of diabetes or any subspecialty of diabetes. Over to Nandita if she wants to make any comment, and then we can.
Thank you. Thank you, Dr. Banshi. First of all, let me thank Dr. Hema Divakar for inviting me here. And I think to hear such an eminent speaker, Dr. A.K. Das, talking about something that is very, very important, because a lot of women do require insulin, and in all parts of the country, we don't have diabetologists. So I think it's very important that every doctor, every clinician is taught how to handle it, how to take care of it, because diabetes has become an epidemic, as you've been listening to it the whole day. So I think we need to, understand how to use insulin when we cannot use oral anti-diabetics. So thank you, Dr. Hema, for giving me this opportunity, and over to you, Dr. Ashok Das ji.
Can I have my slides shared? Yeah, can I? Yeah. Now, see, can I have the first slide? Now, this is very important to remember that we are talking about the use of insulins during pregnancy, already non-diabetic who has become pregnant, or GDM. And our special focus today is the low middle income group, and also the in which India is included. I must hasten to add that we must know that diabetes is a very huge growing problem. Can I have the next slide? Can I have the next slide, please? Next slide. Next slide. So we know that diabetes has become a pandemic, and we had 415 millions in the year. We have a lot of problem because of the GDM. If we do not treat it well, it is associated with serious short-term complications. As we just now discussed, macrosomia, stillbirth, newborn babies, and we have also have preeclampsia. We just now discussed, I'll repeat it again, preterm birth and other complications. Next slide, please. Now, if you go to the problem of GDM, Next slide. We have that not only short term, there's a bigger long-term health impact of the disease. Now, if you look to the long-term health impact, you will find, can I have the previous slide? The long-term health impact is actually mediated through the GDM, where we have the NCDs, and Professor Shesha has given this message loud and clear that GDM has acted as a mother of all NCDs, be it hypertension, be it CVD, be it stroke. Therefore, because we strongly believe today a fetal origin of the adult disease, therefore the NCDs are born definitely out of the GDM or pregnancy diabetes. Number two, GDM also responsible, pregnancy diabetes responsible for the transgenerational transmission of diabetes. And in a country like India, where the GDM is about 17%, maybe this is responsible for the high prevalence of diabetes in the country. So therefore, we have the long-term complications impact like the NCDs, like the transgenerational transmission of diabetes. We have the 50% of women who develop type 2 diabetes within 5 years, and children born to GDM mothers, they develop obesity, hypertension, metabolic syndrome, and also by the time they're 20 years old, there is a 8 times higher prevalence of obesity and diabetes. Next. Dear friends, I'll just like to add here that is the reason why we need a very significant way of treating GDM and giving the risk factors here. So it is possibly important to intervene in the risk factor stage. And I'm sure in the next 2 days, we'll be discussing how to interfere the risk factors to prevent GDM from occurring. Next slide. Now, next, let us come to the focus of the today's discussion. What is the scenario in the low and middle income countries? Dear friends, this is based on our own work, own guideline, which has been developed by Dr. Shesha in the DIPSI group. It has also some inputs from the other countries, where you will find that some inexactitude of the numbers are there, which were changing. Despite the increase in the prevalence of the GDM, it is a neglected issue in the low and middle income countries. Dr. Anil Kapoor is here with us, and his tireless effort has made a dent. I'll come to it in a minute, but it's a neglected issue. And the women in India with GDM strategy, there was a WINGS project of IDF flagship project. They also found that tackling GDM in a low resource setting is a big issue, but bigger than WINGS, we have our own data which shows how to manage this problem in the low resource setting situation. Next slide, please. Now, here I have given the data from World Bank from yesterday about which are the countries which are included in the low income countries, and those were included low middle income countries. You will find that majority of the countries we know: Afghanistan, Burkina Faso, Burundi, Central African Republic, Chad, Congo, and Ethiopia, Guinea, Rwanda, Niger, Korea, Somalia, Sudan, South Sudan, Togo, Uganda. They are actually the low income economies. And I have tried to give some data that how do people manage diabetes here, especially GDM. Now, the low middle income countries, where the income is between $1038 to $4045, you will find that we are included here today. But the World Bank statistics shows that we might be moving up in the ladder to HIG group in a shorter time. But please remember that this is a huge problem in the countries like India, Bangladesh, and also in Pakistan, in Nepal, and various other Cameroon, and various other countries which are the middle income group countries. Next slide. Dear friends, I will add that guidelines on GDM management from lower and middle income countries has been made. I have no time to go into all the guidelines. I have brought 3 guidelines for you. One is the guidelines for managing the hyperglycemia in pregnancy. I must hasten to add that 85% of HIP is because of GDM. I didn't repeat because that has been spoken here already. So 85% of the HIP is because of GDM. And the Society of Obstetricians and Gynecologists from Pakistan, SOGP, published in the Journal of Diabetology their guideline. The guideline for Nepal also has been published in a 28-page document. My friend is here, Dina Sister. She has been authored it. And of course, we have guideline from the Bangladesh, Dr. Fakiruddin, Dr. Shalom, and the entire group from the Bangladesh have taken leadership. And I'm sure it is very gratifying to see that at least there is an attempt. And of course, India has accepted the two diabetic complications as the singularly important complications. One is the diabetic foot, other is diabetic pregnancy. And we have separate societies for that, which is testimony to the fact that how much importance we give. And again, I will not repeat the name again, you know who is responsible for the DIPSI and for this. Therefore, I will just say that these guidelines, however imperfect or perfect it may be, has a definite role to play. And every guideline has 3 sentences, very important. They said the strict control of blood glucose is extremely important. Second line, they have borrowed from our guideline. They say the blood glucose controls to be such that the fetus should never know that his or her mother is a diabetic. Third, they say the treatment of choice for the GDM and pregnancy diabetes is insulin. And there are various types of insulin. There are insulins which can be cheap, which can be used. We'll come to that. What can be used very, very freely and almost giving equal effort, equal impact. Or we can use the other insulin which are high. So therefore, dear friends, the fact of the matter is that we have guidelines. We have guidelines galore in these countries. But I have just taken 3, and again I congratulate Anil for having taken initiative. He has been ignited, and that has been resulted in these guidelines. Next. It is very, very gratifying to see. Next slide. Next. Dear friends, I will not go through details of it, but we have got better data than in low resource setting, how we can manage diabetes better than IDF. DIPSI has given better guideline. I'll confine to that. Next. And next. Now, what the role of insulin in GDM management? Hema, taking cue from you, I have kept my presentation case. Keep it simple and straight. So I'll be giving only simple messages, Hema. Next slide. Now, there are various criteria which you'll see here. Now, you find majority of the guideline today, including IDF, WHO, and DIPSI, says 90 is the target for the fasting. 1 hour can be 140, but we emphasize more on the 2 hour. That has to be 140, but 2 hour has to be 120. And there are some guidelines, of course, I have nothing to say against, but there are some guidelines when the ACOG said that if the FPG persistently above 95, you add insulin. They have possibly also adopted 90 as the guideline. But I will mention wherever they say 95, our objective, very sincere request to make it 90. So this is the time when you should initiate insulin. I'll repeat again. Insulin is often added when, in spite of nutrition therapy, the fasting plasma glucose persistently above 90, 1 hour above 140, 2 hour above 120. By IDF, by DIPSI, same. By ACOG, insulin is often added to nutrition therapy when fasting plasma glucose above 95. But you see, we insist on 90 for only one reason. I will not repeat it again. When the diagnostic criteria is 90, our treatment goal should be also 90. There is the only justification. But you see, we have clearly indicated here when to start insulin in this situation. Next. Dear friend, glycemic targets in India, the recommendations suit Indian scenario for diagnosis and management. Now, fasting plasma glucose, we sometime back wrote in DIPSI, between 80 to 90, 1 hour between definitely less than 140, and 2 hour between 110 to 120. I saw one cartoon which when Dr. Sadhana was speaking about 115, I liked it. And this has resulted in achieving the ideal birth weight between 2.5 and 3.5. So the target is to maintain HbA1c is 6 to 6.5 and mean plasma glucose, as I said, 95 to 105. Our DIPSI key recommendations are one test with 75 gram oral glucose, one value, that is 140 at the end of 2 hours, and one target for monitoring, mean plasma glucose 105. So that's what we want to make it simple. Dear friends, my dear friend Bansi, Dr. Bansi Sabu is here. He's the president of the Asian Study Group of Diabetes, and he invited me this year to attend the meeting. It was very gratifying to see. Bansi would remember that majority of the countries from the Asian countries have adopted the DIPSI criteria. Even when we discussed about the COVID, madam, I will hasten to add that because in the countries where they use other different criteria, IIDPG, etc., they have gone back to DIPSI criteria or one single blood glucose up to 75 gram glucose because of the fact they don't want the lady to come in the COVID time again and again for giving 4 samples of blood or 3 samples of blood or twice. Therefore, DIPSI criteria has been well accepted today, especially for these countries and globally. Next. Now, what is the choice of insulin? Which insulin you should use? I'll be very brief, but I'll say that what is the dictum? Insulin analogs have been used in pregnancy. In our RSA guideline, of which Dr. Bansi Sabu, Professor Bansi Sabu is the presiding officer, we have recommended that analogs are a little better than the ordinary human insulin. They can be used, I'm coming to that. But analogs are a little better because they have flexibility and they have less hypoglycemia. I'll repeat again. I'm not speaking this talk to the very, very eminent obstetricians. I'm speaking to the people who are my students, garden variety of obstetricians, garden variety of physicians. As you rightly said, as Dr. Felskar said, people want to know what to do. So analogs have been used in pregnancy and do not cross the placenta. IDF has said that rapid-acting analogs, rapid-acting insulin like Lispro and Aspar are safe during pregnancy. The usual recommendations is also whenever necessary, I'll come to situation where it's necessary, one can use long-acting insulin like Detamir, or one can use NPH, which is cheap, affordable, available, accessible, and appropriate. It can be also used. One has to be a little careful about the hypoglycemia. Then it is very safe. Now, premix insulins are convenient to be used, but there is a shoulder effect. And if the diet varies, it lacks the flexibility. But premix insulin is also used plenty in the GDM and pregnant diabetes, especially when a diabetic becomes pregnant. I'll come to that in a minute. Now, it has been said that soluble human insulin when you compare with the analogs have certain advantages. 2 are important. One is that less hypoglycemia and possibly flexibility. So therefore, weight gain is better than the ordinary insulin. So they have some advantage. But most important, it is ideal to use human insulin. You do not have any other animal insulin at all in our country today. But I am told in Kerala, one particular doctor prescribes still animal insulin. I have not seen, but I have heard it. It is ideal to use human insulin, least immunogenic. Rapid-acting insulin analogs have been found to be safe and effective in achieving the targeted postprandial glucose value during pregnancy. Next slide. Next slide, please. Now, what are the recommendations of RSDI? We have the presiding officer here for insulin therapy in women with GDM. Pharmacotherapy should be initiated in women with GDM if they fail to achieve blood glucose targets within 2 weeks of initiation of nutritional therapy. Sometimes we do not wait. I'll come to a situation where we do not wait. Ordinarily, in a GDM, we can wait for 2 weeks with nutritional therapy and exercise, upper body exercise or walking. As insulin does not cross the placenta, it is preferred agent in women GDM. So the number 1, number 2, number 3, number 4 treatment is insulin. There are doctors who do not use anything else except insulin, but few of us have our compulsions. We work in government hospitals. I'm in the National Institute. We cannot refuse treatment. So it is there. So insulin Aspar Lispro may be preferred over human insulin, and NPH insulin can definitely be used for basal insulin requirement if you cannot afford, if they cannot afford Detamir, which is expensive. Next. So NPH stands out great. Next. Dear friends, I must also mention that RSGI for insulin therapy in pregnant women with pre-existing, that is, we call it various names, but best name is the pre-gestational diabetes. They were already diabetic before gestation. Insulin is considered more suitable over oral agents in women with pre-existing diabetes. One must remember, they might be taking insulin, they have oral drugs like metformin, sulfonylurea, but insulin is most suitable as they're unable to overcome the insulin resistance by tablets alone. And they cross the placenta and ineffective in type 1 diabetes, question doesn't arise. As individualized insulin regimen and glycemic targets or basal bolus injection should be provided to every individual pregnant woman. We call it customized way of treating pre-existing diabetes. Regular insulin or rapid-acting insulin may be used in women with pre-existing diabetes to improve the postprandial, but they need long-acting insulin like glargine or detamir or NPH with pre-existing diabetes. As I said, alternative NPH in our countries, LMIC group countries is quite acceptable. With similar, I'll declare from the rooftop, with similar perinatal outcomes. Women with type 1 diabetes and insulin-treated type 2 diabetics have received antenatal corticosteroids. We give it, the neonatologists give it for the fetal lung maturation. And there is a separate protocol, which I will not touch upon today, that increases insulin doses proactively while the steroid is being given to prevent hyperglycemia. Next. Dear friends, how should we give the dose of insulin? As I told you, RSGI is targeted for the physicians, for the GPs, for the consultant physicians, not the hardcore diabetos or endos. Similarly, it is targeted for you, madam, who have been very, very adept in the GDM. Now, insulin dosing in pregnancy, there are two ways of dosing. One is weight-based, other is trimester plus weight-based. Now, usually if you're doing by weight, 0.7 to 1 unit per kg, divided doses daily. If it is trimester-wise, in first trimester requirement is 0.7 units per kg, second trimester 0.8, and third trimester 0.9. Now, usually, if you want to give trimester-based, usually give 50% basal insulin at bedtime and 50% divided into 3 meals when we call it a bolus insulin. So basal bolus. Next. Just go back. Can I go back to previous slide, please? Now, usually insulin requirement falls during first trimester, increases already who is pregnant, and increases during the second trimester and third trimester. Please remember this, it will guide you in your treatment. Next. Dear friends, what is the requirement of insulin during labor and postpartum? I was amazed, Sadhana Gupta's questions and the way it was discussed, amazing. I think I must congratulate for the great panel discussion you had. During labor, what is the insulin therapy targets and how do we do it? Our target is to achieve during labor glycemic levels, IV dextrose and insulin dextrose infusion during labor and birth for women with diabetes whose capillary plasma glucose is not maintained between 70 and 110. We can go for the dextrose plus insulin to maintain between 70 and 110. Rapid acting insulin analogs like aspart listro are the preferred choice for achieving target glycemic value as they minimize hypoglycemia. Postpartum, insulin, please remember, insulin requirement falls postpartum by 34%, remember at least 1/3, than the required in preconception period. Over the next 1 to 2 weeks of postpartum, the insulin requirement may return back to that required during the preconception period. Before becoming pregnant, we are discussing pre-existing diabetes. They come back to the square one. Lactation, there is a sharp decline. Please remember, sharp decline in insulin requirement after delivery, and hence the dose of insulin has to be adjusted accordingly. You know, insulin is always adjusted, as we discussed during monitoring, by the blood glucose estimation. Next. Now, what are the various insulin options during pregnancy? You will see the list is big. There are few insulin which cannot be used. Number one, regular insulin. You see in pregnancy, we do not have any time A recommendation. It is B, that is good. Fast-acting insulin aspart, yes, is available. Insulin aspart, now for FASP, we don't have recommendation now. FASP is it's called ultra fast-acting. Ultra fast-acting, we do not have approval yet. Aspart we have, Lispro we have, Glulysin is C grade, Detamir we have, Degludec we don't have yet. Glargine, there's no clinical data on exposed pregnancies from the control studies with U100 Glargine Lantus, but if needed, and people use it, and what is most important is what is clinically useful to people, how they like it, and they come out successful with the pregnancy outcome, maternal outcome, fetal outcome. So people have used it in pregnancy, and the application has been filed. Maybe it will be approved shortly, but people are using it heavily. NPH insulin, yes, B class. The analog insulin 3070, yes. Bipegic Lispro, yes. Mixture 3070, yes. Degludec and Aspart combination, we call it a co-formulation. For the first time, it was introduced country by one particular company, Novo Nordisk, called Ryzodec, but we do not have clinical experience with Ryzodec. It is not yet approved. Similarly, we have got a drug where we combine, for very obese ladies, we give not pregnancy. We give a combination of liraglutide and degludec called Ideglira. Is not yet studied. There's no clinical experience. So Ryzodec, that is Aspart, Ideg-Asp, no. Ideglira, no. Next. Dear friends, I will summarize this part of my talk very quickly. Can I have the animated slides, please? Okay. Now, this I'm showing to bring to the forefront what should not be done. Hema, I'll take only 5 minutes. Within 20 minutes, I'll finish. I'll take only 2-3 minutes to show this. This is the one which was prepared 2014, published 2017. It serves some purpose, but lot of correction it is needed. Why we did this consensus? Because we did not have any comprehensive consensus for the GDM insulin therapy. Hema will agree, and my chairpersons, madam, and Dr. Falsker will agree that we do not have anything. So it was decided to bring out this consensus to provide simple and easily implementable guideline. And it was written very clearly that we bring out something very rough, but we have to improve upon it year after year. So this year, again, we're going to address it. Next. Now it is the highest prevalence of hyperglycemia in pregnancy, 25% is from South Asia region. And hyperglycemia in pregnancy in women between 20 to 49 years by the IDF region is highest in Southeast Asia region. Next, 2015, also 2017 atlas and 19 atlasness. And you see the prevalence of GDM in our country, high, it is almost Lucknow 41%, Tamil Nadu 18%, West India 9.10%, Punjab 35%, Kashmir 3.8%. Next, it almost parallels the IGT in that state. Now, there are various available guidelines for using insulin GDM. So it was decided to bring out a comprehensive guideline. Next. Next, please. Now you will find that these are the insulins which has been, I have again not repeat this, but in that particular guideline, we have given the same thing. Next, same guideline. Now, same weight-based dosing and also the trimester-based dosing. Next slide. So this was published in JAPI, but the corrigendum has come. Now, the division of this guideline was into 4 parts. First part, next one, please. Next slide. Now, the first was a consensus on use of insulin in GDM. The second was consensus of use of insulin in the intrapartum. Third one was the consensus of use of insulin postpartum. And third, consensus on use of insulin beyond delivery postpartum for a long time, how to do it. So I would laud this effort. I mean, it was a laudable effort, even though not 100% foolproof, to give some idea what we should do. And each time it was discussed, what are the indications, what is the choice of insulin, how do you titrate. We also discussed the practicalities, prepartum what to do, intrapartum what to do, postpartum what to do, and we gave some recommendations. But this has been further modified, which we'll see next year. This year, I'm sorry, 2021. Next, please. So it is there that insulin has to be added if medical nutrition therapy is not able to bring down the fasting 90 and 141.20 1 or 2 hours. In the post management of MNT, this is the correct statement by our society, DIPSI. Post MNT management 2 weeks, we initiate insulin if fasting plasma glucose remains above 90 and post 2 hours beyond 120. And the mean plasma glucose, our objective maintain 105. So as I said, fasting 90, 2 hour postpartum 120. Next. And we start with very low dose, 4 units of NPH. Next. Now, if you look to the guideline, the first important thing, the glycemic targets must be 90, 140, 120. Number 2, and we must have a stricter control and must take the family and the lady into confidence for monitoring. Next. These are all in the NICE guideline, ADA guideline, DIPSI guideline. Now, this is fasting 90, 2 hour 120. And we said that if known type 1 having insulin and type 2 being shifted to insulin, we said that when you did not wait for 2 weeks of the MNT trial, if the 2 hour PPG is more than 200, if the first and second trimester 160 to 200, or third trimester is more than 160, if you have seen the patient for the first time during the third trimester, you should start insulin right away. And so we could initiate insulin. If it is third trimester, start insulin immediately. If the second trimester, you may or may not, we do not wait, but people wait for 3 to 4 days a week for the MNT to see how between 160 and 200, the sugar is coming down by MNT. Next. Now, it is about the choice of insulin, types of insulin in dosing regimen. There is nothing new, so I will not take time on it. It is same. It is same saying that use the similar insulin, the bolus insulin, and the multiple rapid acting insulin. Next. Now it also says that it is same thing. I'll not repeat again. It is almost same. All the ACOG, IDF, NICE, and DIPSI guidelines are the similar 90, 120 target, and one can use Lispro as part. I will not repeat again to save time. Next, please. And the choice of bolus insulin we have given. Now, this is the next slide, please. This is important. I just want to see some fine. And we had also given that guideline how much you dose adjust. It is very simple. We always go by -2 or +2, +4 or +6. And we're given the fasting plasma glucose values and increasingly order of adding basal insulin to bring it under control. Bolus insulin, again same, -2, +2, +4, +6. And we're given the various blood glucose level at which these adjustments are made. Next. So this is about the practicalities. This is the prepartum summary. I think it is almost the similar, and we have to have the glycemic targets to improve glycemic outcome. Multiple injections should be used, and rapid acting bolus analogs may be used over regular insulin for postprandial glucose control. It's very difficult to control postprandial glucose if you do not use bolus insulin, and the perinatal outcome may be similar with the basal or with multiple dose. Multiple dose controls the postprandial very well. Next, you can go fast. That is intrapartum. We have said insulin glucose infused. Same thing. I will not repeat again. Next. Yeah, we always believed in a very simple protocol to manage it. Now, if somebody is on the metformin, we stop metformin and go to the management with the insulin. So, dear friends, in the available time of 20 minutes, I have taken 25 minutes. I must tell you that I have just given you a very simple approach that we have the targets well defined, 90 and 120. If you're doing 1 hour, 140. We have insulins. The best of insulins can be used. It must be human insulin. Animal insulin disappeared except very stray cases, and you can give anything except the Ide-Gasp, Ide-Glira. About glargine, it is being given, people give it, and there has been no bad effect so far, but guideline has not yet approved it. You can give NPH, you can give rapid-acting analog, you can give the mixtures, and you can do it. There are few practicalities which I'll say before I close. Normally, we don't combine the analog insulin with the ordinary human insulin. I don't know why, but that is the dictum. Don't combine. You are giving somebody a analog insulin, aspart. Don't combine the same person with a human mixtard. There are some guidelines, and the whole issue is that by hook or by crook, or by hook and crook, you have to bring the fasting 90, postprandial 120 for a great outcome. And we have insulins galore. There has been said there's a relentless advance against relentless disease is advances in insulin. Thank you very much.
Thank you very much, Dr. Das, for that great talk. Dr. Nandita, may we have your comments, please?
I think that was fantastic, Dr. Ashok Das, and especially, all my fear with our minds about how to use, when to use. The guidelines are really very practical and very well put forth by you. Thank you so much. And Dr. Banshi Sabu, is he there?
He's not there, ma'am. So.
Okay.
Yeah.
Thank you, Dr. Das. That was...
Thank you. Thank you very much. So we look forward to the next 2 days program. We'll be joined in and stay put. Thank you very much. Thank you. Thank you, Hema, and my boss, Sital. Thank you very much, both of you.
Thank you, sir. Thank you, sir.
Thank you very much to the chairpersons and Dr. Das for that wonderful session. We now move on to the penultimate session of the day, which is going to be the artist session on new frontiers and fresh thinking. The chairpersons for this session will be Dr. C.N. Purandare and Dr. Usha Sriram. The first talk will be given by Dr. Hema Divakar. She will be speaking on impact of vitamin D and myoinositol on GDM prevalence. This will be followed by Dr. Sanjay Gupte, who will speak about GDM and preeclampsia nexus, what's new. The last talk of this session will be by Dr. Anil Kapoor, who will tell us about how to invest in life course approach and save the next generation. C.N. Purandare has loads of awards and recognitions, as we can see. Dr. Usha Sriram is the founder of Divas, an NGO for prevention and care of girls and women with diabetes and NCDs. Dr. Hema Divakar, I think, needs no introduction at all. Suffice to say that she's an influencer for social reforms for women. Dr. Sanjay Gupte is a very senior and respected member of our community. And Dr. Anil Kapoor, even though he said he's not a mentor, I don't think age has anything to do with it. You continue to be our mentor, sir. Over to Dr. Hema Divakar for the first talk.
Thank you, Purni. This is Dr. Usha Sriram. First, I want to thank Hema for this amazing opportunity, particularly because this topic that we are going to, the topics that are going to be discussed in this session are the closest to my heart in terms of prevention of gestational diabetes, in terms of preeclampsia and gestational diabetes, and of course the life course approach to the whole gestational diabetes and how can we save the next generation. I just want to say that Professor Purandare will have to leave for an obstetric emergency, so you are stuck with me for the whole session as the chair. But what a great honor! I really appreciate this opportunity from Hema and the artist. And so, without further ado, let us go to the rock star of the whole program, Hema Divakar, who will talk about obstetric management in GDM, optimizing pre-pregnancy care, and how can we achieve a normal glycemia. And these are all so important in terms of the outcomes for the mom and for the baby. And now we know about pregnancy as a window to future chronic disease. So we really are talking about next generations. So Hema, over to you.
Thank you, Usha. It's always good to be stuck to you because of a lot of innovative ideas and the actions that those ideas, more importantly. Though we know that we've always been talking about optimizing outcome at 3 different points: pre-pregnancy, during pregnancy, and post-pregnancy. Today, my talk is going to be just for the next 5 minutes to give us our insights into that fact that everything cannot be done everywhere in our country. We know that. So if we can do something to decline or decrease or slash down the prevalence of GDM itself, instead of 5 million women every year, suppose we have just 1 million women, we are 11 times more prone anyway. So what could be that trick? And so we are obviously discovering more and more because of the testing that we are doing. So can a food supplement that could work, which is an insulin sensitizer, double up as a safe and something that can be used for the masses, and something that will sensitize the insulin, something that will help mask or not allow the pregnancy hormones to interfere with the insulin or action, sensitize it better, and prevent the unmasking of the issue of hyperglycemia of pregnancy in the early or mid-pregnancy. Insulin resistance is the key, the whole issue. And we took upon ourselves at Artis first phase research work where we thought that if we could use myoinositol and vitamin D3 combination in the 3 groups prior to pregnancy and in first trimester in the primigravidas who have detected normoglycemic on the first test and beyond pregnancy. So this is a whole continuum. But in the first phase, we decided to target only those primigravidas who, as per the government recommended, FOXI recommended, FIGO recommended protocols, will get their first test done in the first trimester, 12 weeks. And they're proven to be normoglycemic. Can we then supplement them with inositols and see how many of them unfold into the gestational diabetes when we repeat the test again as per the FIGO, FOXI and Government of India guidelines at about 22 to 24 weeks? Will this number decline? So we had a lot of brainstorming with our research associate, Professor Manyunda, and we zeroed down these 5 institutes and did a double arm but triple blind study. The combination which is already available in the market, pioinositol 2 grams, D-chiroinositol 50 grams, and vitamin D3 1000 grams. This is marketed by Shield Healthcare as GDM safe. So my question to them was, how do you know that this is GDM safe? It is safe for GDM, fine, maybe. But what does it actually do? And that is how we hit upon a very, fierce discussion that we need to do and prove one way or the other whether this really helps or doesn't help. They already had the vitamin D3 in their sachet. So we had to match it with the control group, which had only the same amount of vitamin D, just in order to decide for ourselves whether the Myo D-chiroinositol does anything or not. Will these 2 groups behave differently? The one who is given Myo D-chiroinositol with vitamin D3 as against the one who is given vitamin D3 alone. So the primary outcome, as I said, will all those who have reported normoglycemic in the first trimester, how many or what percentage of them will typically show us a hyperglycemia picture in the mid-trimester? So the various inclusion-exclusion criteria, the packet number 003, 005, all centers, the capacity built about how to do a robust, proper documentation and follow the protocols very strictly. Arguably, this is a triple blinded study because it's sachet 003, 005. Neither the clinicians nor the patients nor the company who supplied it knows what is in what. But at any point of time, whenever we test her sugars in the mid-trimester, if she is hyperglycemic, then due course of management of hyperglycemia will follow. That's how we got the ethics approval. And we recruited a total number of 1,324 for all these women and out of which there were a few dropouts. So those who reached the second trimester for the testing were 1,000 plus. And we found 29 out of 543 patients who were given the 003 sachets to have hyperglycemia in the mid-trimester. And out of the 465 patients who were given the 005 sachet, had 17 of them. So overall, if you put this together, the incidence of all those who were given any with sachet was only a surprising 4.6%. So we know that the background prevalence in our own settings is anywhere. We have about 10 to 14% of GDM patients in the mid-trimester for sure. Okay, but the primaries who were given these sachets, when they were tested for the second time, and we really saw the percentage, it was only a 5%. But there was no difference between the group 003 to 005. That means those who were taking myodechloroinositol with vitamin D3 also had a lesser prevalence, as against vitamin D3 alone also had a lesser prevalence. This again brings forth the point that vitamin D3 really may be playing a crucial role. And as per Sir Sheshaya's study, 9 to 17% is the expectation. Definitely 10% even in the public health institutes. But the three major public health hospitals which recruited the patients into this study really showed that the numbers were less. So the concept that is brewing in our mind now is that if there are 80 million Indians in the country with type 2 diabetes, 40 million of them are women. Half of them have become type 2 diabetes because in the first place they got the hyperglycemia in pregnancy, which Anilji always says that it is a spotlight thrown on them. So they have moved on to become the type 2. And there is so much economical burden also. So just like folic acid in pre-pregnancy and throughout, can this food supplement lower the adverse outcomes both in pregnancy and beyond, knowing fully well that there is a risk and much cannot be done? So dietary myoinositol and or vitamin D3, if you look at all the available studies, the numbers are really small. And even in those small numbers, they have concluded that yes, the inositol supplementation can reduce the incidence of GDM, but the combination of vitamin D3 and inositol, will it work for India? Because we have a massive number, we have different genetics, different diets, different lifestyles, and the impact of dietary supplements are waiting to be evaluated, especially because we know that there is a more than 80% vitamin D3 deficiency in our country. So in its own merit, if vitamin D3 is given, and I have heard Dr. Bhavatarini and the group also speak about the role of vitamin D3 in women, especially with respect to insulin sensitization and the GDMs. So our dream is, yesterday we were handling obstetric emergencies, today we are shrouded with the NCDs, tomorrow maybe long-term implications of these cardiovascular diseases, hypertensive disorders, obesity, diabetes, that's what we land up with. So how can we do something simple to avoid this? So there is a lot of buzz we need to create around this. At least let's start. As always, we believe something better than nothing. So maybe this study may even go to an extent that vitamin D supplements is something that is really called for. Incidentally, if it spins off a lesser number of the gestational diabetes in the country, a few millions less every year, which will be a less burden for the OBGYNs for all the kind of surveillance and the tackling that they have to do. So more and more, as we are going towards digitalization, we want to make the whole community aware that this is really a huge problem in our country, and whoever can have any kind of data to report to us that simple things like food supplements may work. First of all, do no harm, so the safety is guaranteed. And if a mass supplementation blindly can be followed, at least with vitamin D, that's what this study seems to be looking at, because there's no statistical difference between the two groups. Ideally, now we are moving towards our next phase of study, and we will discuss it with Dr. Gupte and others, that we need the three prongs. One is vitamin D alone, One is vitamin D, myoinositol, D-chiroinositol combination as it's already available. Then another is myodichyroinositol alone. So those three segregated groups will show us who is doing what, which of these ingredients is really playing a role. But in this study, the limitation was that the product already available was myodichyroinositol vitamin D3. Since we have the literature that vitamin D3 also plays a role, we couldn't have just compared it with any placebo to claim that myodichyroinositol is doing a great job. So we had to, we can't compare apple to oranges as how we always discuss. So these three arms, if we move ahead and do, I can see Picky on the screen, and we have a claim that she has the richest knowledge and experience in the research in our country. I'm really impressed with her insights and her work. So maybe we will do something more large scale, but in principle, the quest for something simple, something safe, something that can be given to the masses, something which can reduce the prevalence of the gestational diabetes, mellitus, or hyperglycemia in pregnancy to a significant extent will go a long way in changing the overall scenario of this tsunami in our country. So that's my humble submission. Thank you.
Thank you, Hema. I think we're going to reserve all the questions to the end. I think after your talk, vitamin D and myoinositol, I think we should start looking at it as maybe something like a folic acid, which has become standard of care, and also maybe gently push the government towards food fortification with vitamin E. It's happening, but I think that's also something, I think this will give them a good nudge in that direction. So let's have a discussion and then invite Professor Sanjay Gupte for the next very, very important talk on the nexus of preeclampsia and gestational diabetes. Sir?
Please bear with me. I think this is a little different talk that has come in. So I'll go back a little. Okay.
This also sounds like a good talk.
Yeah, because two simple things that we have been telling our obstetricians now is breastfeeding initiated within 1 hour of birth, and breastfeeding to be continued at least for 6 months to help them lose weight and to help them decline the prevalence of long-term issues with hyperglycemia as well. Sanjay?
Imagine till Dr. Sanjay Gupta gets on. I wanted to make a comment.
If you would like to go ahead. Sure.
Yeah, I think can we ask Dr. Kapoor to present first, Sanjay, by the time you can sort your slides out? Yeah?
Yes, no problem.
Yeah.
Till then I'll find my, properly.
Sure. So the tech team can just stop the slide share of Dr. Gupte. Yeah, and permit our next guest, Dr. Kapoor, who is in the process of packing and flying off to London at the midnight. I'm really, really grateful to you, Anilji, for still making time, not only to do your presentation, but to be here with us right from the start.
So are my slides visible?
Yes.
Okay. Hemaji, before I start this presentation, I wanted to make a little comment about the study that you presented. I think it's a very good beginning, but we need to also ensure that we are able to do a study which is pretty good match controls, so that it's not just about different risk factors playing out in different sides of the study that bring about this difference. Right. So I think we need to plan these studies much better to be able to get a real good answer. But it's a very good beginning, and certainly it's an important issue to deal with.
Thank you, Anilji.
My remit for this presentation is to talk about how do we invest in the life course to prevent NCDs and save the next generation. So if you look at it, one of the biggest issues of why we are seeing such a high burden of NCDs is perhaps because of the developmental mismatch, which has been very appropriately described. It's because of the economic transition, urbanization, acculturation, and technology adoption that we are changing the way we eat, live, and work, and the environment that we are exposed to. And societies in rapid transition show these changes very rapidly. And this is why we see that countries like China, which moved millions and billions of people out of poverty, has the highest rates of diabetes today in the world. And that is how we are also experiencing this in India, where a large population has moved out of poverty, and we are starting to see a rapid increase in the rates of diabetes and NCDs in our country. So it's basically a mismatch between the past, that is in utero survival programming, and the new socio-economic reality in adult life. And the ability or the inability to cope with these changes seems to be at the core of this NCD pandemic. And therefore, preconception health of parents and health of mothers during pregnancy and lactation becomes a very important determinant of population health. Now, we know from the developmental origins of health and disease that maternal health is critical for fetal development and programming. So the maternal health, nutrition, placental physiology, and exposure to environmental pollutants, and this is something that we need to consider quite significantly now, given the exposure that we have to the environment pollutants, and especially exposure of pregnant women to these, have significant impact on developmental programming. And therefore, the interaction between the fetal environment and the genome determines growth and development and cause of alterations in gene expression, leading to programming for adult health. Now, we have seen this slide many times before. Basically, it is both sides of the equation: maternal undernutrition, stunting, anemia, malaria, and other medical conditions leading to low birth weight, as well as conditions such as maternal overweight, obesity, diabetes, excess weight gain during pregnancy, leading to macrosomia and large for gestational age baby. And both sides of this U-shaped curve represent a very high risk of impaired glucose tolerance, type 2 diabetes, and hypertension. So therefore, ensuring that the babies born are at the most appropriate for their population is very critical in ensuring that we are able to prevent NCDs. Now, just look at this. Globally, if we say that there are about 130 odd million live births that happen, 56 million of these live births are impacted by maternal anemia. About 26 million are impacted by maternal undernutrition. About 42 million are impacted by overweight and obesity. 21 million of these have exposure to hyperglycemia in pregnancy, and about 10 million of these pregnancies or these children born live have been exposed to maternal hypertension. Now, if you look at all this conundrum, you'd wonder how come we are still surviving as a human race, because this is basically the basis of what we are going to suffer in decades from now, until and unless we stop this from happening. So if you look at South Asia's burden of these select maternal conditions, anemia impacts about 21 million pregnancies out of an estimated 37 million live births. Undernutrition, 17 million, obesity, 7.5 million, hyperglycemia, 8.5 million, and hypertension, 2.5 million. Now, given this status, it is not surprising that we are seeing such high rates of NCDs. So my take on this is very clear, that pregnancy actually provides an interchange between undernutrition in previous generation and overweight and obesity, IGT, type 2 diabetes, cardiovascular disease in the next generation. And with increasing NCD risk accumulation in subsequent generations due to higher rates of obesity, IGT, type 2 diabetes, etc. And therefore, to me, when people say that diabetes is not communicable or NCDs are not communicable, I'd say that they may not be communicable, but they are transmissible. And this is mother to child transmission. pay so much attention to HIV mother-to-child transmission, I think we need to focus a lot about how the risk factors for NCDs are being transmitted from mother to child. So low maternal birth weight, being born to a mother with history of GDM diabetes, physiological effects of pregnancy exaggerated in early life programming, leading to higher rates of GDM, higher rates of GDM in the next generation, and the cycle of vulnerability repeats. And this is particularly important when it's a girl child, because if she's born to a mother with gestational diabetes, the risk that she will have gestational diabetes and overweight and obesity is extremely high. And therefore, we need to be very clear that NCDs adversely impact maternal health, and poor maternal health increases the risk of NCDs. So my proposition is that in most parts of the low, middle, and upper middle income countries that account for 85% of global deliveries, 90% of all maternal and perinatal deaths and poor pregnancy outcomes, and 80% of global diabetes burden, it is, and that we know that hyperglycemia and pregnancy contribute significantly to increased risk of all these complications that are listed here. And it's amazing that we still debate whether all women should be tested for hyperglycemia during pregnancy. Pregnancy is, to me, a window of opportunity for to future health of mother and offspring. And pregnancy is an early life stress test. And I think we all need to understand that women, that pregnancy is the biggest stress test that a human being can undergo. And women fortunately go through this. And if they come out fine, they are in great health. But if they do not, it is a marker that they have a future risk. And therefore, pregnancy complication and outcomes need to be used with greater frequency to stratify, triage, and target women and offspring at higher risk of NCDs. And as Hema said, I always like to say that these pregnancy complications actually put a spotlight on the women. We should not let her walk away from this spotlight without ensuring that she and her child receive adequate preventive and promotive health care. So complications such as gestational diabetes, hypertensive disorders of pregnancy, excess weight gain, dyslipidemia, and also adverse pregnancy outcomes in terms of preterm birth, fetal growth restriction, intrauterine death, recurrent pregnancy loss, placental abruption, and other placental syndromes, they're actually markers of future NCDs for the mother and also the offspring born to this pregnancy. Therefore, we need to improve preconception and interpregnancy care. And if the proposition that giving vitamin D supplement can reduce the risk of gestational hypertension, gestational hyperglycemia, then it is something that must be done forthwith. And the other issue is that we need to increase the acceptance of preconception services and universal preconception screening. And we are talking about hyperglycemia and pregnancy, but I think we will be not doing a great job if we also don't focus about screening for anemia, obesity and overweight, diabetes and other thyroid dysfunctions. And therefore, in FIGO, where I work very closely with Hemaji, we have actually made a big ask that public health measures to increase awareness and acceptance of preconception counseling, to increase affordability and access to preconception services of women of all reproductive age. And this is likely to have both immediate and lasting benefits for maternal and child health. The other important point is that we might diagnose and manage women with hyperglycemia and pregnancy, but let me make it very clear to everyone, we are doing nothing about preventing type 2 diabetes in the offspring and the mother by just managing hyperglycemia and pregnancy. All of it has to happen also with postpartum care. Without postpartum care, without postpartum preventive efforts, we are not going to be able to reduce this risk just by ensuring good care during pregnancy. And my proposition on this is very clear, that we have to link this not just to the care of the mother, but we need to link it to the care of the child, because that is something the family and the mother will be focused on after pregnancy. And we need to link it with the vaccination program, where the child would visit, the mother would visit with the child healthcare setting for at least 5 years. And this is the opportunity that we must use to address these issues. So to me, a great start to life, if we want to give the best gift to the offspring, is the fetal environment represented by the mother's and periconceptional and gestational health actually determines whether one starts life with a health advantage or a health handicap. And it is on this foundation that NCD risk factors play out in later life. People starting life with a health handicap may be less able to withstand lifestyle risk and may be vulnerable to developing disease early compared to those starting with a health advantage. And therefore, if we want to give the best gift to the new generation, it is to ensure that they are born to parents who are in prime of their health. We talk about life course approach to prevention, and of course it's very important. A lot of words are used about it, but it's very important that if we have to implement a life course approach, it has to be like a relay race, because one specialty alone cannot deal with a life course approach. And therefore, it is important that we learn to pass on the baton from one specialty to the other as life progresses. And to be able to do this, it is very important that we have good health records and electronic records, and digital health issues, which can then be used to ensure that these risk factors are known and can be dealt with going forward. So I would say that one of the greatest improvements that can be brought about in the present generation is to actually ensure that every pregnant woman has health records which are digital, and that it is linked to the child's vaccination program and so on and so forth, so that these records can move forward as the child progresses in life. The FIGO Pregnancy and NCD Committee has made a position statement, and I wouldn't go into all that, but I'll just like to say that pregnancy offers a unique opportunity to integrate maternal child health services with health promotion and NCD prevention, thereby providing a bridge to create integrated services at the primary care level. And therefore, we need to stress that global public health action on NCD prevention and control must begin with and substantially focus on integrated and comprehensive maternal health, which is preconception, antenatal, and postpartum, and the health of the newborn child. So what are the things that we need to do? And I think Hema is touching on all of these aspects in her work every day. We need to create huge amount of advocacy, address educational, political, and social issues through advocacy and awareness, link the NCD agenda to the maternal newborn child health and sexual and reproductive health and rights agenda to advocate for more resources. We need to ensure that women ask for these tests to be done, to ensure that they feel empowered that they would ask for these tests to ensure that they are in the best health during pregnancy or even before pregnancy. Provide access to maternal child health services as well as care for NCDs at the primary care level. Avoid making the best the enemy of better, and this is why guidelines such as the DIPSI guideline is so very important, because we don't need to live in ivory towers and talk about the best academic solutions without focusing on what can be done on the ground. We need to integrate services, ensure record keeping and tracking mechanisms, link postpartum follow-up with well baby vaccination programs, build outreach activities using community health workers and midwives, promote healthy lifestyle among adolescent girls and pregnant women. And all this requires the investment that needs to be done to ensure that we have a generation next that is healthy and wise. So for me, I'd like to end, and this is a slide that has been used very many times by many people. Pregnancy offers a cost-effective window of opportunity to provide maternal care services to reduce the traditional maternal and perinatal morbidity and mortality indicators, but also cost effectively address the intergenerational prevention of NCDs. And therefore, if we want to say what do we need to do in investing for the health of the future generation, I'd say we need to focus on the health of girls, young women, and women during pregnancy. And I think that is the best investment that a country can do in terms of not only improving human capital, but also improving productivity and health of the nation. Thank you very much.
Thank you, Dr. Kapoor, as always, so inspiring, and I think motivates everyone to get on the bandwagon and do more work. Thank you so much. Do you have time to stay for the questions, or would you like to take it now? And
if I'm allowed, I would like to take a few questions.
You're allowed.
But I'm sure there would not be many, because this is a thing that everybody knows and understands.
Really, if anyone has any questions, please put it on, post it on the chat. If any of the other,
I think Usha, we will allow one question from you to the Anilji.
Oh, no, I'm.
Ask him. What is your ask from Anilji, please?
He has all the answers. The thing is, I've been a great fan of his, link to the vaccination program, recommendation. So my question to you, Dr. Kapoor, is: should we start a program where we empower pediatricians and about GDM and mother and infants of GDM as an educational program, capacity build on that side, and build the capacity of OBGYNs on this side about how to, and like you said, hand over the baton. And because pediatricians really will not have had the training to take care of moms. So should we start a program to train them?
Dr. Usha, the problem is that the solution is so simple and it doesn't need high technology, that often the barrier occurs when there are no high technology investments involved in things like that. I think it's very important that every mother who is discharged after delivery and the new child health card is created, we need to put a mark on that card, which indicates that this is an offspring of a mother who had a pregnancy complication, not only just gestational diabetes, but gestational hypertension or whatever, premature delivery or whatever. And we need to obviously involve the community health workers, the nurse midwives, the whole health system around it, because the vaccination is such an important element of the national health program. And it only needs that kind of a link to happen. And we can teach these health workers simple messages: why the mother should ensure she loses weight, why she needs to exercise, why she needs to eat healthy, why she needs to breastfeed. Simple 5-10 different messages that every time the mother comes with a baby for the vaccination, those same messages are repeated. And it doesn't take too much for that health worker to also weigh the woman and say, you have not lost weight. Just pointing that out, that you need to do something about it. Involving pediatricians is, of course, very important. And I would say that we must make Indian Academy of Pediatrics as a very constant part of these discussions. I have tried to involve the pediatricians at the international level. They all show interest, but somehow the message falls between the two chairs. But we need to do this in a more systematic manner. And I would say certainly we should involve the Indian Academy of Pediatrics and make them involved in our programs.
Thank you so much. Thank you so much. So if there are, let me see, there is one that has come up in the chat box. No, it just says, wonderful talk, Dr. Anil.
Yeah, can I just put one more point, because sir has exactly hit the point. which anyway we are covering in the panel discussion next, because this is a one big question on how to follow up these women. We know now that GDM leads to NCDs or hypertension leads to NCDs. And then excellent point which Sir has given, and I think we should really work on that. Wonderful, Dr. Kapoor, your ideas are, this has been there for quite some time, and we are going to discuss it more in the next panel. Thank you.
I just wanted to say that obstetricians have the greatest collaboration with pediatricians and neonatologists. And therefore, you have the best possibility of involving them into this initiative. And that would create such an important link between the two specialities that can only be possible through obstetricians. It will not happen through diabetologists and endocrinologists. It can only happen through obstetricians. Thank you very much for allowing me this opportunity to interact, and all the best for the rest of the session.
Thank you, Anilji. Safe travels. Dr. Gupte, from breastfeeding to GDM and preeclampsia, what's the nexus?
Okay. Dr. Usha, thank you for bearing with me and being in the chair, and Dr. Hema and Dr. Anil Kapoor, two visionary speakers. And after that, I'll give a little more, food for thought in one more NCDN opportunity that we always miss out on during, pregnancy and after. So GDM and preeclampsia nexus, what's new? Right, let's move the slide if we can. Again, I think there. Okay, something wrong with the moving of the slide.
Sanjay, there is an icon here, maybe at the bottom of your screen.
Front
arrow, is it not moving?
Okay, right. Sorry again. So these GDM and preeclampsia, I call them unrelated relatives. And why that is so, GDM and preeclampsia may appear to be unrelated disease entities, as their clinical manifestations and diagnostic criteria do not overlap. But many studies have proved the correlation between the two. If we look at the pathophysiology of first preeclampsia, we know that it is a multisystem pregnancy-specific disorder presenting new onset hypertension and proteinuria after 20 weeks of gestation. It is obviously a leading cause of maternal and fetal mortality. And our FOXI ICOG National Eclampsia Registry shows that preeclampsia prevalence is as high as 10% in our country. Well, we know that preeclampsia is a two-stage process. First stage is asymptomatic, involves abnormal placentation, producing placental hypoxia and oxidative stress, inflammation, apoptosis, and which is followed by placental elaboration of soluble factors that enter the maternal circulation and cause widespread endothelial dysfunction with signs and symptoms, the so-called maternal syndrome. Clinically, also preeclampsia is of two types. One is the early onset preeclampsia, onset before 34 weeks. Here the maternal complications are more severe with placental hypoplasia and higher number of placental vascular lesions. The late onset preeclampsia, that is onset of 34 weeks, here the maternal complications are less severe with placental hypoplasia and evidence of placental inflammation and absence of vascular insufficiency. So this actually suggests that preeclampsia might be more than a single condition that we are always labeled with. GDM, of course, we know is defined as hyperglycemia that is first diagnosed during pregnancy. The prevalence of GDM in India was 16.55% in urban India and 9.9% as per our godfather of this DIPSI, Dr. Sheshaya study. And GDM develops due to inadequate supply of insulin to meet the tissue demands of pregnancy. And this insulin resistance leads to increased levels of glucose production and free fatty acids with subsequent increased blood glucose levels. all forms of diabetes, GDM type 1, type 2, increase the risk of preeclampsia. And the incidence of preeclampsia increases from 2 to 7% of pregnancies in non-diabetic women to 15 to 20% in type 1 and 10 to 40% in type 2. And GDM remains as an independent risk factor for development of preeclampsia. So there are common risk factors in both preeclampsia and GDM. And what are they? Advanced maternal age, nulliparity, multiple pregnancies, non-white ethnicity, and pre-pregnancy obesity. And even if you look at the long-term sequelae, both have common long-term sequelae, with preeclampsia increasing the risk of future cardiovascular disease, stroke, kidney disease, ophthalmic problems, and while GDM increases the risk of future cardiovascular disease and type 2 diabetes mellitus, both in mother and the child. Well, both have so far enigmatic origins. We do not know very specific pathophysiology of both as yet. And a combination of maternal risk factors contribute to the similar biochemical dysregulation present in both preeclampsia and GDM compared to healthy pregnancies, such as endothelial dysfunction, angiogenic imbalance, insulin resistance, oxidative stress, inflammation, and dyslipidemia. This again suggests that the shared etiological pathway underlying both these conditions. And there are common triggers. And what are they? Again, these biochemical changes might result from a common etiology and have a common trigger, or be similar responses to different underlying disease processes that existed even prior to pregnancy. So similarly, genetic and environmental factors that contribute to preeclampsia could also increase the risk of diabetic complications later in life, or it could be just as possible that preeclampsia causes lasting damage that leads to diabetic complications years after pregnancy. Let's look at endothelial dysfunction. As we have said before, the maternal uterine artery, limited remodeling that occurs in preeclampsia causes hypoxia. The damaged placenta then releases factors into maternal circulation. These include SPLET1 and soluble endoglin, and excess of these anti-angiogenic proteins contributes to systemic maternal endothelial dysfunction in women with preeclampsia. Well, again, these anti-angiogenic factors are important because the relation between anti-angiogenic factors and preeclampsia with women is now getting clearer. Zhao et al. Found that women with GDM have higher serum SPLET1 levels, PP13, PTX3, as early in the second trimester, with SPLET1 and PTX3 having potential predictive value even in GDM. So quantitative proteomics of sensory trophoblast from women with GDM and preeclampsia identified 11 upregulated and 12 downregulated proteins, including increased split. So a lot of commonality in the pathophysiology. And Powers et al. Showed that high endoglin, high SPLET1 and low PIGF and high SLIT-PIGL ratio increase the odds of developing preeclampsia among women with pre-existing diabetes. So let's look at insulin resistance. Again, so many authors have compared, showed that compared to normotensive women, women who develop preeclampsia are more insulin resistant even prior to pregnancy. And this we know because in polycystic ovary syndrome, both things are comparatively common. The same was found in women that develop GDM presenting chronic insulin resistance and chronic beta cell function prior to pregnancy. We look at the oxidative stress during normal pregnancy, generation of reactive oxygen process is known to be increased and is necessary for proper physiology. However, both preeclampsia and GDM present a reduced antioxidant status when compared to normal pregnancies with increased levels of protein and lipid oxidation products. And Samarda referred to the inflammatory process. And here again, cytokines play a very important role after ischemia and reperfusion injury. Together with oxidative stress, the placenta mounts an inflammatory response releasing cytokines and other inflammatory factors such as TNF-alpha, IL-6 and CRP, and damaging levels of ROS. These are characteristics of preeclampsia. Women with GDM also had higher serum levels of TNF-alpha and IL-6 in the third trimester compared to women with normoglycemia during pregnancy. Again, adipokines is something very interesting, which again Samarda referred to in his talk, and they have very peculiar actions in both the condition. Adipokines, which are actually proteins secreted from adipocytes, are involved in a wide range of physiological processes, include lipid metabolism, blood pressure regulation, insulin sensitivity, angiogenesis, immunity, and inflammation, and have been shown to play a role in normal pregnancy. In both preeclampsia and GDM, various adipokines are dysregulated and could be pathophysiology of these conditions, especially since obesity is a known risk factor for both. It's interesting to see that increased concentration of adiponectin were found in women with preeclampsia, which actually could be a mechanism to counter the inflammatory response and improve insulin sensitivity and vascular function. Inversely, exactly opposite, decreased concentrations of adiponectin was found in women with GDM, which might further aggravate insulin resistance since adiponectin has insulin sensitizing effects. Well, genetics, of course, is very important in both these conditions. Primary gravida with a family history of preeclampsia have a 2 to 5-fold risk of developing preeclampsia. That Chelsea, in even 60 years back, actually proved. Then genetic factors play a role in increased split-1 production and placental size in the maternal contribution to develop preeclampsia. So, a few studies have looked into genetics of GDM now, and genes linked to GDM participate in cell functions involving cell activation, immune response, organ development, and regulation of cell death, similar to preeclampsia. Well, the epigenetics or the DNA methylation is, of course, again very important because the lifestyle itself affects it, the stress affects it. So the effect of preeclampsia and GDM on the intrauterine environment also bring about epigenetic modification, including DNA methylations. Studies measuring CpG island methylation found a predominance of hypermethylation in the placentas of women with preeclampsia and also GDM. This hypermethylation in the placenta might be due to oxidative stress, since both preeclampsia and GDM are associated with increased oxidative stress. Again, so this is something, again, Samarda referred to, and that was the microRNA expression pattern in placenta changes throughout the pregnancy due to the involvement of microRNAs in regulating different aspects of trophoblast biology. A number of studies have identified over 100 differently expressed microRNAs in the placenta or sera of women with preeclampsia compared to normotensive controls. And in the sera of women with GDM also around 50 microRNAs targeting various inflammatory pathways such as TGF beta signaling pathways were discovered. And this is something very interesting that I have found that, we talk of metformin for, prevention and treatment of GDM, but it has a huge role now proved also in prevention of preeclampsia. Metformin, as we know, is a small molecule that can readily cross placental barrier. It is the treatment of choice for GDM due to its efficacy and safety for the unborn child compared to insulin. Metformin was shown to be superior to insulin in reducing the frequency of gestational hypertension and possibly preeclampsia. Here, metformin acts by reducing reactive oxygen species production, reducing endothelial dysfunction, and reducing split-1 and endocrine secretion regulated through the mitochondria. This suggests that there are similar perturbations in the cellular energy balance of patients with preeclampsia and GDM. So in conclusion, much of the biochemical dysregulation that is common to both GDM and preeclampsia suggests overlapping pathophysiology. However, the available data does not clearly outline a common etiological pathway, mainly due to limited analysis power to compare the different patient groups. Detailed evaluation of pre-pregnancy characteristics and clearer distinction between the different disease status, that is early versus late onset preeclampsia and type 1 diabetes and pre-existing type 2 diabetes, GDM, is required. To achieve this, prospective cohort studies need to be set up in which biochemical data is collected from women at preconception at each trimester during pregnancy and postpartum. Gaining a better understanding of shared and separate pathophysiological pathways would help improve screening and treatment of both the diseases. So finally, the key points: a combination of maternal risk factors appears to contribute to the similar biochemical dysregulation present in both preeclampsia and GDM. The common biochemical characteristics underlying these conditions include endothelial dysfunction, angiogenic imbalance, insulin resistance, oxidative stress, inflammation, and dyslipidemia. A detailed evaluation of pre-pregnancy characteristics and clearer distinction between the different disease status is required to better understand the shared and separate biochemical pathways. So this is how these unrelated relatives fall together, and we have to look at this new aspect, and especially the metformin action in both very keenly, and we already started working on that, and there are some actually other medicines which are commonly used, like the various prazols and statins, which are being now used to reduce or prevent preeclampsia, and that's the newest aspect of this. Thank you so much.
Thank you so much, Professor Gupte. I've been asked by Hema to wrap up the session because Professor Tanawala's session has to start on time. But really, we have had such a brilliant, talks on the potential tool for prevention of GDM, the life course approach, pregnancy as a window to future chronic disease, and of course the unholy nexus of preeclampsia and gestational diabetes. I thank all the speakers. Thank you so much, Hema and Professor Gupte, and of course Dr. Kapoor. Over to Dr. Tanawala.
So we are moving on to the last session of the day, which is the FOXY ICOG session, where we will have a panel discussion on GDM today, NCD tomorrow, opportunities to action. And to moderate this session, we have Dr. Uday Thanawala. Dr. Uday Thanawala is an eminent obstetrician and gynecologist from Navi Mumbai, who's also the chairman-elect for the Indian College of Obstetricians and Gynecology 2021. The panelists for this talk are Dr. Anjalakshi Chandrasekhar, who is the ex-president of DIPSI, and she is also graduated from Kilpauk Medical College and has a PhD in pregnancy diabetology from the Tamil Nadu MGR Medical University. The next panelist is Dr. Bharti Kalra, who is a consultant at Bharti Hospital, Haryana, and is a certified diabetologist from Newcastle, Australia. Our next panelist is Dr. Anuj Maheshwari, who is the professor and head in medicine, BBD University, Lucknow. Other distinguished panelists are Dr. Bhavatarani, who is the honorary professor of diabetology, state IMA, and also the state coordinator for diabetes IMA course, and is a faculty in diabetes training program in DPH at Tamil Nadu government. Dr. Parag Binewale is a senior consultant from senior OBGYN consultant from Pune. He's also one of our panelists, and he's also been the secretary of the ICOG 2018-2020. So at the end of panel discussion, after Dr. Uday Thanawala has finished with the panel discussion, we will be having Dr. Chitra Selvan, who is an endocrinologist at the Ramaiah Medical Hospital, Bangalore, to speak on the role of optimal post-meal glucose control. So over to Dr. Uday Thanawala.
Yeah, Pune, I would like to share my screen, and I'm not being able to do so. Yeah, okay, I've got it. So thank you very much, Hema, and thank you for this opportunity, and welcome to all the panelists whom we are going to talk. And the whole session is basically on GDM today, NCDs tomorrow, and we've been talking a lot about it. And the point is how to get it into practice. That's what we're going to look at in this panel today. we have some clinical situations which one has to tackle. And then keeping this NCD in mind, that this girl tomorrow may have a problem, how do we deal with that? Dr. Anil Kapoor in his lecture has given excellent inputs about putting it on the baby's card and linking it to the pediatricians, and we will talk more about this in this panel with all our esteemed panelists. So we have this 29-year-old patient with a BMI of 26 who was discovered to be a GDM in this pregnancy. Now, she was controlled only on diet and exercise. Like 90% of the patients whom we discover are controlled on diet and exercise. She delivered a 2.9 kg baby. So what are the instructions, Dr. Parag, which you will give her after her delivery when she's going home?
Okay. Thank you, Uday. First of all, the diet and exercise pattern which she had started to control her sugars has to go on, because what is extremely important is monitoring sugar. So if her gestational diabetes is controlled only on diet and exercise, maybe before we discharge the patient on the third or fourth post-delivery day, we should get a fasting and postprandial sugars done. And of course, when we send her home, she has to continue following a good diet pattern. Unfortunately, the diet that is fed to the breastfeeding mothers is full of carbohydrates, and that is something which we need to avoid. The second issue women who have gestational diabetes face is challenges with breastfeeding, because it is observed that these women...
1 minute. Sugar monitoring, when, how frequently, when to repeat, and when to do it?
Right. On the third day before we send her home, if these sugars are normal, we will call her back after 6 weeks. Yeah. Right. And after 6 weeks, we would suggest a DIPSI test for her again. Right. And then depending on the sugars that we get on DIPSI test at 6 weeks, we will decide the further course of action. If the sugars are normal, then she has to control her diet and continue doing exercises. But if her sugars are abnormal, say the 2-hour post-glucose is more than 140, then she definitely needs to see a diabetologist in order to monitor her future.
So her 6 months sugar is normal. Her OGTT,
6 weeks.
Six weeks OGTT is normal. When next do we ask her to repeat?
She should be doing it every year.
Once a year, very important. Okay, you were on breastfeeding. Sorry.
Yeah. So breastfeeding is something which many a times women struggle with this, but then they do need good counseling. The third thing that we've already talked a little bit about is diet and exercise. Yeah.
Breastfeeding is going to help her to keep her sugars also under control. So that has to be
continued, and that will also help her reducing weight to a certain extent. Yes. Right. And the fourth aspect is contraception. Now, a good counseling is required for her next follow-up, that is after 6 weeks. Women who have gestational diabetes are eligible to receive all sorts of contraceptive options. So you can offer them barriers, LARC, they can be offered progesterone-only pills or DMPA, but only when women who have gestational diabetes and may have some macrovascular disease. In such women, we will certainly avoid estrogen-containing preparations. So no COCs, no implants, no rings. But rest of the contraceptives,
this one is controlled only on diet and exercise.
Only on diet.
She could be a candidate for COCs. Any of my other panelists would like to add anything more to this? Or any other warning for the future health? Anybody, any panelists would like to add something? Dr. Anjali Lakshmi, Dr. Bharti. Yeah, Anuj. Sorry, Dr. Anuj is speaking.
Follow-up is very must. So actually, after 6 weeks of GTT, if it is normal, then also we have to continue them with the follow-up, repeat them about the diet, review how much diet they are taking, what type of diet they are taking, and the exercise, and the importance of the diet we have to explain to them and keep them under our nose.
Constant care.
Right.
Yeah, Dr. Anuj?
Yeah. As she has been found GDM in the pregnancy, although it has been controlled on diet and exercise, so she is carrying very high risk for being diabetic. So such patients should not be offered steroid-based contraceptions.
because they may become diabetic any day, and it may cause some. I just wanted to add this thing.
Yeah, Dr. Bharti, any inputs?
We should counsel her about weight reduction, because she should get her pre-pregnancy weight by the end of 1 year.
Yeah.
And so she should try to get ideal body weight by this 1 year, and with lactation, her weight will reduce. So if we tell her ideal body weight and her target, if she loses 2 kg per month, that will also be okay, because usually with diet, as we have told that the diet and exercise are reduced after in postpartum period and afterwards. So we have to counsel her again and again. And if we give her the target of weight reduction, that will be better for her.
How many women come back at 6 weeks, come back at 6 months, come back at 1 year to the obstetrician? How many do? Do you think, is it a good number, Parag or Dr. Bharti or Dr. Anjalakshmi or Dr. Bhavtarini, any? Do you think they will come back?
At the time of discharge, we tell them all our targets.
We tell them everything, but how many actually
because
come back? What is the callback rate in your practice?
In my practice, at 1 week, maximum patients return, because if they are a normal delivery or after cesarean, they come for follow-up.
Yeah.
And for 6 weeks, we give them in writing that they have to come when they come for baby's immunization, they have to get their follow-up at 6 weeks, and they visit.
Excellent, because we need to do something. Yeah, Dr. Bhavrati, you were saying something?
Actually, as you said, not even 20% turn up for
Yes.
follow-up. So I always go with the Dr. Anil Kapoor, what he said, I'll get along with the pediatrician in this to follow both the mother as well as the child. That's what I feel.
Yeah. I think it is important, because in all our clinics, we have our pediatricians coming for the delivery. And it's high time that when they give that discharge card to the baby, we should be mentioning in red or putting some mark that this mother needs follow-up. And I think we should start doing it in our private practice, so more and more mothers will be ultimately covered. So now let's discuss a case where this patient who is 32 weeks, she's on diet, exercise, and metformin. Now she comes to you with an ultrasound report saying that the baby is 30 weeks. There's a lag of 3 weeks because abdominal circumference is only 29 weeks, and the like it is marginally less. The BP is, blood pressure is normal. She is now very worried when you give her this information that the baby is small, and the mother-in-law is sort of blaming you, Dr. Bharti, that bachcha chota hua because tum bola usko sugar nahi khane. Now how do you deal with this?
So that is counseling of mother-in-law is very, very important. And to counsel her, if we counsel any patient's mother-in-law, that is your best achievement, because she is the one who takes care of kitchen. She is the one who provides food, different types of food to her daughter-in-law, because the pregnant woman is young girl. She may or may not be knowing the things. So in that case, first thing, because we have to tell her she is a patient of GDM. इन नॉर्मल लैंग्वेज हम कहते हैं कि जो उसको प्रेगनेंसी में शुरू में ही शुगर ज्यादा थी, तो उसके कारण उसकी ऑर्गनल ठीक नहीं बनी. दैट मींस द प्लेसेंटल फॉर्मेशन वाज नॉट ओके इन फर्स्ट प्लेस. दैट इज व्हाई द बेबी इज if we put a wrong seed, or if we don't give a good environment in the early time of pregnancy, just like if we implant any seed, so the result is seen after some time. So in this stage, the result of GDM is seen at this stage, 7th or 8th month of gestation. So, but it is not because we have told her to stop taking blood glucose. In one sense, it is she may be right. Means if we give her insulin and if we follow very strict control of blood glucose level, in that case, or she is if she is a patient of type 1 diabetes, or she was detected early in pregnancy.
She's only on metformin. She's only on metformin.
But in this particular case, she is on metformin. And
so
this is not because...
tell her that it's not the restrictions which have caused the small baby. It is something like a vasculopathy, and one has to be careful for that. And how will you manage this patient? Dr. Anjalakshmi, would you ease out the sugar control now since the baby is
No, sir, no. See, I always keep the target levels of fasting less than 90 and postprandial less than 120. That is very important. That could be some other reason for the IUGR. It is not the GDM. First, when we are counseling the mother-in-law, we should tell the mother-in-law that there are so many reasons are there for IUGR. It is not the GDM. If it is the pre-GDM, it can be associated with vascular problems, but she is only a GDM. So we have to counsel her, and I will not ease out the sugar control. And regarding the metformin, that is the most controversial subject now. Actually, to my opinion, no, I will not stop metformin. As Dr. Sunil Gupta was telling, that is the use, not Sunil Gupta, somebody was telling, no,
yes,
metformin has a role.
Yeah.
Now the recent literature are coming that metformin can be used for the treatment of IUGR in a non-diabetic, non-obese individuals. So the animal experiments are over. Now it is coming. So the recent literature, metformin is supposed to be helpful for IUGR.
Yeah,
so
but
I
we are
will
going to
not
give her
stop
for
metformin.
We are going to give her because it is keeping her sugars well under control. So we will continue metformin.
Okay.
And
of course, the IUGR cocktail I'll give for their satisfaction. We will advise complete bed rest and give the IV protein, ARG9. All
Madam,
those
bed
things
rest,
we can use.
Bed rest is not really that important. I mean,
bed rest in the
make her
sense.
sugars more abnormal if she's completely on bed. So it is better that she does some movement. And generally, what we advise is restricted bed rest, where she can take rest for 1 hour after breakfast, 2 hours after lunch. Restricted bed rest is okay, but not a complete bed rest. But otherwise, one can use the different regimes for IUGR. But how will you monitor this fetus?
Okay. Uday, just a quick comment about sildenafil now. Though sildenafil has been promoted in management of growth restriction, there are reports of intrauterine fetal demises with sildenafil. So I really don't think for such a high-risk patient we should be offering sildenafil.
Yeah, because people are using it left, right, and center just without too much of evidence for it. So all these things are not really more evidence-based. Protein, yes, one will increase. Little bit of bed rest is important. The others are just adjuvants.
Yeah.
So how about monitoring the fetus, Parag, and when will you interfere?
All right. So the best way to monitor these fetus is by doing an ultrasound. So in ultrasound, we will look at two things. One is the amount of liquor, whether it is the same, it is increasing or decreasing. That will tell us a little more about the placental function. And of course, Dopplers are extremely important because Dopplers will actually guide us as to how the baby is doing, and then that will also be a pointer for delivery. Of course, if the facilities for Doppler are not available, maybe we can compromise and do a CTG in these patients, and that would be twice a week at least.
Okay, excellent. So you will monitor by Doppler and AFI, and just to bring out the point that in IUGR babies for GDM, the Doppler is more important versus a large for gestational age baby or a normal weight baby, because the Doppler may not be very accurate then. But in IUGR, definitely it gives you the point. Whenever decompensation occurs, please interfere and pull the baby out if it is a IUGR baby, which a GDM patient has. So this patient delivers at 37 weeks, a 2.1 kg baby boy. What are the postnatal instructions you will give her regard to her and the baby, Dr. Bhavna Ratni?
Yes, the first important thing is postnatal care is more important than prenatal care.
Yeah.
Sugar monitoring, of course, it depends on the blood sugar level. If it is more, continue monitoring and insulin accordingly. And mainly watch for hypoglycemia in the baby. Already it is underway. And advise frequent early feeding. Since the baby weight is very low, even you can think about putting it in NICU. Once delivered safely, do not think everything is over. Now only the mother and baby has to be followed with an eagle sight to prevent diabetes both in the mother and the baby in the future, because they are the potential candidates. And mother has to be checked, as said earlier, once after 45 days and 6 months and every year. And preconceptionally, next time prepare her fit to conceive with proper BMI and HbA1c well under control. And of baby, start breastfeeding early and continue for a long time. This prevents childhood obesity and diabetes in the future. In the mother, breastfeeding reverts back all the metabolic aberrations which occurred in the mother because of glucose intolerance. And mainly, as Dr. Anil Kapoor said, note on the baby score that it is a IUGR baby due to GDM. That's very important.
So I think this is one point which I think each of us, those who are logged in today, should start applying in our practice, that when it's a GDM who's delivered a baby, we must put it in their pediatric card that this baby is at risk of developing NCDs in later on. So, we have to prevent this child from becoming obese in childhood. We have to give the child breastfeeding and keep a watch on the side. It's like the pediatrician will make a note of it. If we tell them that, okay, now this baby is delivered, please mention on the card before they go home that this baby needs to be followed up very carefully, because IUGR in itself is one of the causes for cardiovascular diseases in future. Another case, 31-year-old second gravida presents with hyperemesis at 7 weeks gestation. Patient had a previous delivery with you around 12-13 years back, which you remember was a difficult delivery, and you remember because the patient had shoulder dystocia and the baby has Erb's palsy. It was a 4 kg baby. At that time, you were patching your back that I took out a 4 kg baby vaginally, because we were all very, very keen to vaginal deliveries. Random sugars were only done in the pregnancy, and they were normal because there were no guidelines to do a glucose challenge test. So that is what has happened 12 years back. Now she comes to you. Now you are wiser. In the first visit, you do a 75 GCT and it comes to 195. And her HbA1c is 7.8. So, Parag, what was missed and what should have been done?
All right. So I don't call myself wise, because with such a big history of a 4 kg baby with difficult vaginal delivery and neonatal complications, I have definitely missed gestational diabetes mellitus in that pregnancy.
Yes.
Now, this is a patient who has to be counseled really well. And we did discuss about this in the beginning itself, that she has to be made aware that she is likely to develop gestational diabetes mellitus whenever she plans to become pregnant next. So she is the one who would have been benefited had she been following up with you or with a diabetologist. Now, best thing would have been she comes to you before she plans the conception, and when you're looking back at her history and discussing with her, we would certainly like to get her HbA1c at least done before she thinks of planning a pregnancy, and we probably would have diagnosed her to be having diabetes, because if at 7 weeks she has HbA1c of 7.8 and 75 GCT is 195, that means she is diabetic, which we probably missed.
Yeah, because there was no standardization way back then, and we used to just do a random sugar and let the women go, and it wouldn't even sort of strike us that there's something wrong. So now we have the proper screening guidelines, which we are very thankful. Everything is crystallized so clearly. When to do the test and which test to do, that all is now properly crystallized. And how do you manage this, Dr. Anuj, now? How do you manage this patient since she's come to you with a little high HbA1c and a sugar which is high?
Thank you, Dr. Uday. First of all, patient is coming to us with hyperemesis. We must rule out the ketoacidosis kind of the things at this time. If she is not having that, of course, the hyperemesis is to be controlled, hydration is to be maintained, because she must have lost a lot of water, etc. But this is the right time to start the treatment for the hyperglycemia, because she is entering into the organogenesis phase, and this is the time when she will be impacted most with this hyperglycemia. She is already known, she must be having the pre-GDM, because HbA1c is 7.8. Yes. Although fasting glucose level is not so high, but postprandial is quite high, as well as HbA1c is saying the whole story. So we should not wait for the MNT test or MNT trial for 2 weeks. We should start MNT and insulin together.
Yeah,
at this time. And of course, we must investigate her for anomaly scan, because there are high chances patient may be exposed to the hyperglycemia during the phase of the organogenesis. So T5 scan or whatever anomaly scan are available to the healthcare giver point. They should be done to rule out whether any anomaly is there or not. If it is there, then we should think about that sacrificing this pregnancy. If it is not, then definitely we can continue with the same.
So So one is the sugar, which we totally agree. Now, this is one patient who requires insulin. She's in the first trimester. We need to get the sugars bang under control. We can't give her a trial to let the sugars come to normal. So we start her on insulin. Let us also not forget that she needs to undergo a medical evaluation for other things like the retina and the kidney function test, etc.
Yes, yes, definitely. Kidney function test should be done. As I am thinking about the diabetic ketoacidosis, we should always think that the other things which may give rise to that, we should also go for the liver function test. We should also see the thyroid function test at this time. And all these investigations should be done together with that. And rapid acting insulin or short acting insulin should be preferred to her, and these things should be done. And if there is any abnormality coming up in these investigation, we can go ahead accordingly.
Yeah, so we increase the insulin dose accordingly. So Dr. Yes. Bhavratani, I'll address this particular question to you. She comes at 26 weeks with uterine contractions. She's got mild activity, the os is closed. You're not sure whether she's going to go into labor or no, but will you give her steroids at this time? And if you give her steroids, how will you give her the steroids? How will you adjust the insulin dose?
Definitely, I think steroids.
Yeah, Dr. Bhavratani can answer this.
Yeah. That's what I'll definitely give steroids, monitoring the blood sugar, because once you give steroids just like that, you can't give, you need to increase the insulin dose. On the very first day, you increase the night dose by 25% and do the first dose, and the following days, you have to increase by 40% and give the next dose. And on the subsequent third day, again, you have to increase all the doses of insulin by 40%, then step down from fourth day onwards to 20%, fifth day 10%, and only on the sixth day you can revert to normal.
Yeah, so diabetics who require steroid pulses and who are on a higher dose of insulin and the sugar, you may even have to admit them, to do that, because one of the precipitating factors could be ketoacidosis. Because here we had this patient who came with intractable vomiting after all the steroid dose and upper abdominal pain, and she was not responding to the regular symptomatic therapy of Digene and PAN, and she was becoming breathless and tachycardia. So what will you think of when a diabetic comes to your clinic with pain in the upper abdomen, uterus is not contracting, blood pressure is normal? Dr. Chandrasekhar, what all will you think of? What all differential?
So we'll think of ketoacidosis.
Yeah.
And we have to do the investigations and start treatment first, because they will be with the dehydration. So start on IV fluid, and also check the potassium level, the electrolytes. And after the IV fluids, if the potassium level is low, you start on insulin. In the beginning, don't start straight away on insulin. First give IV fluids, check the potassium level, and then start giving the insulin in the form of infusion, short-acting insulin. 0.1 kg, 1 unit per kg body weight, you start the insulin infusion.
Yeah, so before we just go to
electrolytes,
we must just remember, in a diabetic, please remember the precipitating factors which can cause ketoacidosis. One of them is the steroid therapy which we give, and the other is hyperemesis, as Dr. Anuj mentioned. Dr. Bhavratani, can you even elaborate anything else?
Yeah. Here, what happens, since the blood sugar is 486, it's obvious it's due to diabetic ketoacidosis. But if it occurs early in pregnancy, I think of hyperemesis gravidarum, because she has protracted vomiting. In diabetic pregnancy, infection is very common because of repeated PVA examination or other things. It's very common. Sometimes, if you're not educating the patient properly, there can be non-compliance with insulin. This again can raise the blood sugar and precipitate DKA. And also inquire about the medications. As you said, she may be taking prophylactic steroid or Retodrin to prevent premature labor. All these can again raise the blood sugar and cause DKA. And she is on insulin pump. She should be well aware about the functionings of insulin pump. Otherwise, you can have pump failure. This again can precipitate DKA. And again, just because of the enlargement of the uterus, it can push the stomach up and compress the intestine, which again can cause protracted vomiting. Keep in mind all this. Just don't jump into the conclusion. But here it is obvious. Blood sugar is very high, 486, diabetic ketoacidosis.
So you have your blood glucose level, the blood ketone level, and the bicarbonate level to help you to diagnose ketoacidosis. And as one question which she has already answered, Dr. Chandrasekhar has answered, but if Dr. Anuj could elaborate a little, being an obstetrician, this patient comes to us first. What all we should do before we send the patient to a ICU or a higher center or a medical center?
The most important thing in diabetic ketoacidosis is correction of hydration, correction of dehydration. Even it is more important than correction of the hyperglycemia. Once you start doing the dehydration correction, blood volume increases, and a lot of hyperglycemia also is taken care at this time with the increasing blood volume. So correction of hydration is very much important. Intravenous fluid therapy at least.
So fluid therapy, what will I give with? Ringalactate?
Yes, of course, normal saline is the best one. If the patient is not hypertensive. But in the condition, if the patient is hypertensive and you need to take care of that part also, then ringalactate can be accepted for that purpose. And if the blood sugar level is less than 250, we can start with a 5% dextrose neutralizing with insulin also. But always to be very much careful regarding the potassium level.
No, that I think the obstetrician will not start.
No,
he will send her to you to start.
Yes, obviously.
I'm asking you what the obstetrician should do. So first is give a fluid therapy.
Yeah.
And as Dr. Anjal actually very correctly mentioned that you can give insulin, but that insulin has to be given even if the potassium level is normal, right?
Yes.
So because if you give IV fluids,
if the potassium level in fact is normal or it is on the higher side, then insulin, if you are giving insulin, you will be safe because potassium will go inside of the cell. So it will not be problem. But if the potassium is on the lower side, it will be immediately cardiovascular crisis may occur if the potassium goes inside and heart may stop in the diastole.
So don't be in a hurry. Just hydrate the patient first. And if you can't do the electrolytes levels, send her only on hydration. Just don't start insulin without doing the potassium levels. So that is one message we can give it to all the obstetricians if they ever deal with a case of ketoacidosis, right?
Serum electrolytes.
Yeah, if you're dealing with ketoacidosis, one should remember this simple couple of things as an obstetrician. So, okay, now patient is in diabetic ketoacidosis. Parag, what is the effect on the fetus?
Okay, first of all, we should know that ketosids are the ones which are going to cross the placenta. So they are definitely going to have impact on the fetus. And the various changes in the mother, so maybe maternal acidosis or hyperglycemia or even volume depletion will have detrimental effect on fetus, and the fetal mortality which is associated with diabetic ketoacidosis is pretty high. It is to the tune of 9 to 36%. And we are really not sure about the long-term morbidity that is associated with it, because there are few studies where, they have mentioned that women who develop ketoacidosis during the course of pregnancy may have, the offsprings may have lower IQs in such patient actually.
So, Dr. Chandrasekhar, will you terminate the pregnancy now?
No, sir. No.
What
we don't terminate. We monitor the fetal well-being and take effective steps for the treatment of ketoacidosis for the mother. Yeah. We have seen cases where the mother has delivered after a few weeks of the treatment of ketoacidosis and baby was okay. But we don't know about the long-term effect.
Yeah.
But we have delivered a live baby.
So when you have a patient with ketoacidosis, you may get an NST which is not really very reassuring, and you may get a very bradycardia or something, but that doesn't mean that
we have to terminate.
You have to terminate. So that's excellent. So all these points one should remember, because ketoacidosis can occur. And Dr. Bhavratni or Dr. Bharti Karla, anybody, in majority of the cases, if you continue this, what is your aim? How will you now counsel the patient? She's recovered from that course of this ketoacidosis. Now she's back. What do you tell her to do? How in future to continue her pregnancy?
Sir, continue monitoring. Still, you stabilize her and resolve the ketotic state totally, completely. And again, she can have recurrence of decay in future. So you have to educate her. I have told all the precipitating factors early, and she has to go for frequent carbohydrate containing feeds, or infections. She has to be treated early, and educate more about the insulin compliance. And also, if she's on a pump, she should learn about all the techniques. So she should have adequate diabetic control and in further course of pregnancy.
Okay, so that's important to tell her that this all has happened because the sugar was not under control, and now she should be educated to keep it very well under control and prevent any precipitating factor. Now, Dr. Bharti, this is something not related, this case, the scenario, it is to any patient of GDM. Any patient of GDM, like we heard in the last panel also, there was a debate, and Dr. Piki was saying that, okay, 39 weeks is the time when they all want to deliver. Some of us want to, at 38 weeks, we want to say, Arey, 38 ke baad, we don't know, we get sudden stillbirth, so let us deliver. So the Government of India guidelines do say that well-controlled diabetes wait till 39 weeks. And if there are some risk factors, etc., anyway, the obstetrician takes a call. I want your opinion. Is it that simple to follow guidelines? And I must tell you, Dr. Bharti Karla has a very elegant paper on this, so I'm addressing this question to her.
It's really very challenging, and it is individualized from patient. It varies from patient to patient whether we can follow these guidelines or not, because the timings and mode of delivery depends upon the, if we say it in the simple terms, biopsychosocial and environmental model of deciding the mode of timings of delivery. So in biological model, we can see the medical health of the patient, whether if she is uncomplicated, then it's easy that we can take her to up to 39 weeks. But we have to see other factors also. These factors involved, that is just like the environmental factors, whether the doctor is accessible, if she can approach the hospital easily, if she has any long journey, or if she has any mode of transport, or any person accompanying to her. If all these things are available, even at odd hours. If we say in North India, in winters are very foggy, so it is very difficult for patient to reach hospital well in time. So in those cases, we have to decide from where she is coming and how and when she can approach the hospital. That will be a factor in deciding the timings of delivery. And moreover, if she is having any other complicating factors, means if she had in previous pregnancy, if she had some history of IUD, or she is a case of previous cesarean, or she had microsomia earlier, or any high risk factor in previous pregnancy or in the current pregnancy. If she is ending up in macrosomia at present, or she is having hydramnios, means that means she is not well controlled. So there are chances that odd hours she will end up in leaking, or she may end up in the labor pains. So in those cases, we have to consider all these factors. Or if she is having IUGR, she can't monitor her fetal movements, or there is compromised placental maturity as seen on ultrasound. So if all these factors are there, then we have to deliver her at less than 39 weeks of gestation. That is the early term gestation. We can deliver her, and definitely in medical factors we will come to know about uncontrolled diabetes, or if she is having otherwise a retinal or renal complications. And moreover, sometimes in societies there is a very much stigma attached to the cesarean, because in day-to-day OPD we see if the ultrasound shows at 36 weeks, ultrasound report shows the fetal weight around 3.2 kg. So the patient just calculate that by the time we reach term, the baby will be 4 kg, and then you will say that baby is good size baby, so we will go for cesarean. This happens routinely in our OPD. Even today also the patient's attendants were like this. So in that case, they want early delivery so that their patient can deliver vaginally. And there will be, because being obstetrician, we know the risk of shoulder dystocia. We are also very much worried So if we are confident that we can deliver her at early term with the normal delivery, that is her psychological factors, or her husband or her family members are convinced. So in those cases, we can take her up for induction of labor with the consent of patient and her attendants. So this should be shared decision making practically. So if they agree, because at times, even if we try for normal delivery and she lands up in cesarean, even then the blame is on doctors. So that is why the timings is very important. Keeping we can't leave GDM as a separate issue.
Yeah.
So I want to tell one thing.
Yeah, sure.
So this patient, suppose if we are deciding for delivery before 39 weeks, it is better to give a steroid dose with the monitoring of the blood glucose. So because the lung maturity is being delayed in the hyperglycemia. So it is always better to give a steroid dose when we are trying to deliver before 39 weeks.
Yeah, Dr. Chandrasekhar, I don't know what the other panelists would say, but I would feel that at 38 weeks, before 38 weeks, yes, we would definitely give a steroid. After 38, generally we would not probably give steroid because the woman is also a diabetic and maybe she doesn't need it. And I think at 38 weeks, even if she's not got the steroids, the lungs would be pretty much mature. What would you say, Dr. Bhavratni or Dr. Parag? Or...
No, sir, the audience incidence is more actually.
There was this the recommendation which came that before 39 weeks everybody should get a steroid dose, but I really don't know whether it really makes too much of a difference. 38 is I think what we were anyway. We were taking 37. After 37, we never used to give steroids a couple of years back.
That is for non-GDM people, sir. GDM persons.
No, GDM people, we always wait till 38 weeks anyway. Yes. You want to add something, Parag?
Uday, what Dr. Anjalakshi is saying is absolutely fine. The RCOG does recommend a steroid dose for any patient who is delivering before 39 weeks.
Yeah, any patient.
But in gestational diabetes, I think it probably makes sense for us to administer it. Of course, we are anyway monitoring her sugars closely because these are the patients who are later on more likely to develop even transient tachypnea of newborn. So if not, the steroids will help in preventing that as well. And secondly, I think you've taken this particular thing, and that's absolutely valid because all guidelines are so confusing. WHO says that you can wait till about 41 weeks if the sugars are well controlled only on diet. No, this is WHO says, not my. And then all guidelines are absolutely confusing. So we need to individualize each and every patient. As you rightly...
in India, we say that 38 weeks is more or less the cutoff.
And we are delivering between 38 and 30.
Yeah, I believe there was a nice guideline where they said discuss delivery at 38 weeks. Even if the patient is well controlled, discuss delivery at 38 weeks. Bharti, what is your take on steroids at 38 weeks?
So, because in Indian population, the lungs mature earlier as compared to the Western population. So, we keep it up to 38 weeks. 38, 39 weeks, we don't give steroids. And for GDM, one thing I want to convey, for GDM patients, before giving steroid, must do our urine ketones. Because in the last scenario, at 26 weeks labor pains, so in that patient, if we do ketones, that maybe she might be getting uterine contractions because of her ketosis. She might be in already ketones were positive, and moreover, we can reduce the dosage like 8 milligram 12 hourly for 3 doses, not 12 milligram for 2 doses.
No,
just reducing the dose.
Let's not confuse the audience with.
Okay.
We keep it as a standard dose. Dr. Bhavratni, what is your take on steroids at 38 weeks and beyond?
Yeah, that's what I say. I think lung maturation is complete. I don't think it will be useful beyond that. Surfactant deficiency causes RDS.
Okay, now one quick point before we close is what Bharti said about induction of labor. Now, there are studies to prove that induction of labor in a diabetic patient of a baby, at around, if you are doing it at 38 or 39 weeks, you are inducing labor and trying to prevent an LSCS by giving a normal delivery. Yes, there is a significant improvement in the diabetics compared to the non-diabetic population in a large baby. That is one of the studies which I had come across. So any other comments before we sum up the follow-up methods and how to make it more effective. One very important point is we should be collaborating with our pediatricians and getting them more involved so that they recognize that this mother is the one who was a GDM and she should go back to the concerned doctor or physician. Beyond that, any other ideas or any other comments, the last 2 minutes we have.
The lifestyle measures for both the mother and baby is very important, because the mother has to prepare herself for the next pregnancy, and the baby will develop obesity and IGT in future. So lifestyle measures are very important for both the mother and baby.
Yeah, Dr. Anuj.
So pre-pregnancy counseling is very important, sir. Actually, the GDM people, before they plan for the next pregnancy, they should come for counseling.
And another important thing which I have realized is, unless you start hammering the postnatal follow-up in the antenatal, unless you start hammering it in the antenatal at every visit, they will clean forget. If they've heard it 10 times in the antenatal ki jana hai, doctor ko dikhana hai, sugar karna hai, then they will remember. So start hammering it in the antenatal period. That postnatal follow-up is important and they're prone to become diabetics in future. Yeah, Dr. Anuj, any comments?
Yeah, we can develop some SMS message kind of the things after 6 weeks and 6 months, which can remind the patient that it is very much needed, that it is time to go to your doctor or get your glucose level checked.
So one is
nothing works.
But nowadays social media, SMSs, all these messages, they are at least easily available, and everybody's on the mobile and they're looking at it. So if we hammer them,
HIV, ART, they are doing that, sir. Actually, for HIV treatment.
Yeah.
They are giving the SMS message and seeing that whether they are taking the drug regularly. So like that, we can follow it up.
Another important thing is post-delivery messages to these patients at that particular time that, okay, have you got your sugars done? What is your weight? Please contact the doctor or something like that.
Yes.
Excellent input, Dr. Anuj. Excellent. Anything else anybody would like to say?
Best thing is to coordinate with a pediatrician.
Yes.
Because we have tried all. They are different prenatally.
Government can give some incentives, sir, for follow-up, actually, as they are giving for the delivery. For the follow-up also, they can do.
Okay, I think that's great. So I think we can sum it up now. Thank you so much for all the valuable inputs. The way forward, collaborate with the pediatricians, use the media like SMSs, etc., bulk SMSs to catch these patients and follow them up. That will ultimately have effect, if not now, a little later. And once we tell them that that baby needs follow-up and you have a healthy, unless you do a healthy lifestyle, how are you going to tell your child to have a healthy lifestyle? So they should be having a healthy lifestyle themselves. And please don't forget the husbands. Even they need to follow a healthy lifestyle, because we always talk to the women and we have the husband with a big paunch. So we should counsel the whole family about this. And thank you so much for being with us. And thank you, Dr. Hema, for inviting us for this.
Thank you, Dr. Uday.
behalf of all
Thank
the
you,
panelists,
Dr. Hema.
thank you very much.
Thank you,
Thank you,
Hema.
Dr. Hema. Thank you, Dr. Uday.
Thank you.
Hema, thank you for
Thank you, Dr.
collaborating
Uday, and thank you
with
all the
ICOG also.
panelists for a very wonderful panel discussion, which was very, very practical and very relevant. So now we are almost on to the last session of the day, where we have Dr. Chitra Selvan, who's a professor and consultant endocrinologist at Ramaiah Hospital, who will be talking on optimal post-meal glucose control. This session is supported by Novo Nordisk. So Dr. Chitra Selvan, please.
Thank you, Dr. Rita Singh, for that kind introduction. Thank you, Dr. Hema, and the fantastic organizing team for giving me this opportunity. I know it's been a long day of intense discussions and learning. I'm going to very briefly highlight one specific point about the correlation of post-meal glucose control and GDM outcomes. And we now have such interesting long-term data coming out that it is important to pause and reflect on this very, very briefly. And while we've all spoken about perinatal and pregnancy outcomes and fetal related and neonatal outcomes, I'm going to stretch the arc a little bit out and talk about outcomes purely in terms of really long-term metabolic outcomes for the child itself. And much of this is going to come from the follow-up which has happened from the HAPO study. Would you believe it that it has been almost 13 years from the time this landmark paper was published? I feel really ancient and old. I'm going to briefly discuss some of the salient findings of the original paper itself, and then present some interesting data about the follow-up trial, and then tie it all back to post-meal sugars and outcomes. So large number of people, about 23,000 odd people, 9 countries. They had a 75 gram OGT done between 24 to 32 weeks. What is important to remember is that data was blinded if fasting sugars were less than 105 or 2-hour plasma glucose level were 200 milligrams per deciliter. So what this essentially enabled us is to accumulate large amounts of women across the spectrum of plasma glucose level, be it fasting, 1 hour, 2 hour, and we've been able to follow up through the pregnancy to assess pregnancy outcomes, but we also now had an opportunity to follow up the newborns to mothers across these glycemic window, and then look at some of their metabolic parameters and outcomes as well. We are all very well aware what the primary and secondary outcomes of the original HAPO study was. We are also very well aware about how there was a strong and continuous correlation between all glycemic parameters, fasting, 1 hour and 2 hour, when they looked at very crucial primary outcomes, be it macrosomia defined as birth weight more than 90%, or primary cesarean section, or cord blood serum C-peptide greater than 90th centile. If you're going to zoom in and break this down into the 3 individual components, which is fasting, 1 hour and 2 hour, you do see that there is a slightly greater odds ratio for the 1 hour post-meal OGTT value, especially when you're looking at birth weight and C-peptide levels. So there was probably some indication to suggest that probably post-meal values did slightly better than fasting in certain key aspects of perinatal outcomes, which was what the HAPO original study tried to look at. But what about outcomes for the baby? Of course, there's also the question, many people do go on to ask us, are these cutoffs too stringent? Are we over-diagnosing gestational diabetes? Are we medicalizing pregnancies? Are we just wasting our breath talking about this? So this is also an argument to shush that concern completely. So now in 2019, we have follow-up data of the mothers and the children born of the cohort of HAPO, where they try to look at whether the mother had GDM or not, and at 10 to 14 years of the child, how the child's response to a 75 gram glucose test is doing. Now, this is really interesting finding. 4,000 and odd children aged between 10 to 14 years were followed up, and they were administered OGTT to diagnose the presence of glycemia as impaired fasting glucose, impaired glucose tolerance, and whether there was type 2 diabetes. And this is what they found. The first 2 bars are looking at impaired glucose tolerance, and C and D are panels which are looking at impaired fasting glucose. Notice that in mothers whose levels of sugars were higher as diagnosed by the IAD-PSG diagnosis, the odds of the children getting impaired glucose tolerance were close to 2 times higher as compared to mothers who did not have GDM itself. Of course, there was no significant correlation with fasting glucose levels, but impaired glucose intolerance, there was a correlation. And of the various parameters that were present, notice that it was the 1 hour and the 2 hour value, and not as much the fasting value, which correlated with the child's insulin sensitivity and oral disposition index at 10 to 14 years of age. So this is absolutely crucial information. It is not only reiterated that the diagnostic criteria that we are using are very, very valid. It has also highlighted which sugar that should you focus on when you are trying to diagnose and treat mothers with GDM. Just one more paper, which is again looked at the same thing, but this is not a yes or no question. Did the mother have GDM or not? That's not the question. They tried to look at the range of glycemia of the mother and tried to correlate with, again, metabolic outcomes in the child where they've administered an OGTT, right? So this is the second follow-up paper which has been published in 2019. And again, 4,000 and odd children have been willing to participate in this. And here you have 3 different colors on the panel. The red bar is for the maternal fasting glucose, the green triangle is for maternal 1-hour glucose, and the blue triangle is for the maternal 2-hour glucose. And notice that when you're trying to look at either the child's 30-minute glucose value or the child's A1C levels, there seems to be a greater correlation with the maternal 1-hour glucose than the maternal 2-hour glucose itself, okay? And moving on to other parameters of insulin sensitivity in the child, you also notice that the child's impaired glucose tolerance levels or the child's insulinogenic index, all of them seem to correlate better with maternal post-meal values of 1 hour and 2 hours, maybe slightly greater strength of association with 1 hour than 2 hour itself. And this is an estimated latent class trajectory evaluation of maternal glucose levels and the outcomes in children. Remember that red is for fasting, green is for 1 hour, and blue is for 2 hours, that the correlations are stronger for post-meal as compared to fasting levels. So quickly to summarize, there is a very good correlation with maternal glycemia with long-term children's metabolic outcomes, with the correlations being stronger for 1 hour and 2 hour as compared to fasting levels. And all of these associations are independent of maternal and child BMI. And if you're wondering what is the clinical relevance of this and how do we move forward, probably the clinical relevance is in how we go about choosing how we bring the sugars down to those targets. So we all know how glucose release happens during a post-meal in a normal individuals. We know the time of action of regular human insulin. We also know that analog insulins probably have a much shorter onset of action and a much shorter duration of action itself, closely mimicking the insulin secretion in a normal person physiologically. We also now have ultra fast acting insulin, which is definitely shown to be much shorter in duration of action as well as a much faster onset of action itself. Now, there's also evidence to suggest that the postprandial glycemic excursions are known to be much lower with the ultra-fast using analogs as compared to analog insulin itself, to the tune of 12 milligrams per deciliter. Now, in any other context, this 12 milligrams per deciliter might be a delta which doesn't matter at all. But probably the only clinical context where this delta of 12 milligrams per deciliter might have some clinical meaning or clinical relevance is probably in the context of gestational diabetes. So moving forward, maybe we should have more studies which are specifically looking at outcomes related to the use of ultra-fast insulin or analog insulins in specific design studies which are looking at long-term outcomes. So quickly to summarize my talk, of course, there is evidence to suggest that offsprings exposed to untreated GDM in utero are insulin resistant and have limited beta cell composition. This correlation is much stronger with post-meal glucose levels in utero. In childhood glucose and insulin resistance, now we have follow-up data to the tune of 10 to 14 years. In 1987 was when the St. Vincent's Declaration was taken to improve pregnancy outcomes of women with diabetes to the level of those in non-diabetic population within 5 years. And now it's been a solid 30 years since this declaration, and we are inching and moving towards realizing this dream. And I thank Dr. Hema and Dr. Rita for giving me this opportunity, and I'm hoping I finished in time.
Thank you so much, Dr. Chitra. I think your talk was really crisp and it was absolutely the cherry on the cake. So we come to the end of today's virtual Congress. Team Artist and Team DIPSI thanks all the faculty, the 2,200 plus delegates who were part of today's deliberations, and also the tech team from Science Integra. And we wish to host you all again once more tomorrow at 4 p.m. That is the 14th of March. And I'm sure we're going to have many more deliberations and discussions to look forward to. A very good night to all of you. Thank you.
Thank you.
Namaskar. Thank you, everyone.
Thank you.